So we will be starting with spotter number 5 to begin with, and then head over to the others orders. Okay. The order of the presentation also shared in the chat box. Tejasvi, shall we get started?
Yeah. Okay. We have
Yes.
different people presenting individual cases. I first welcome Dr. Hemlata, our professor, uh, to present the first case. What you mean? Student has to present. No, just introduce yourself and
Yeah, I am
ask.
Dr. Hemlata. I will be presenting spotter number 5. I think Ankita, you can go ahead and present your
Yes,
presentation.
ma'am. Yes, ma'am.
Ankita, please go ahead and share your screen and start your presentation.
Yes, sir.
It's your screen is seen. Please start your presentation.
Is it visible, sir?
Yes, get started. Dr.
Good
Ankita.
afternoon to all. I, Dr. Ankita. Yes, sir. Good afternoon to all. I, Dr. Ankita Agrawal, postgraduate in Sri Siddhartha Institute of Medical Science and Research Center, T. Bengaluru, Bengaluru. So, spotter case is allotted to me, labeled as a S5. The history is given as a 60-year male presented with a recurrent urinary tract infection. Ultrasonography of abdomen revealed a bladder mass. Transurethral bladder tumor slides is a resected bladder tumor slide provided. So in the scanner view of the virtual slide image labeled as a S5 shows multiple fragments of follicle epithelial lining, underlining congested vessels and lymphoid aggregates. This is another scanner view which is provided. On the low power view, we can see a lymphoid follicles and many dilated and congested blood vessels. These all are the blood vessels. And here, the area of hyperplastic urothelial lining seen with the focal microcystic changes. Other area shows mild hyperplasia of lining urothelium and underlying subepithelium shows sheets of foamy macrophages. On 20x, we can see a lymphoid follicles below transitional epithelium. On high power view, sheets of neutrophil and lymphoplasmacytic infiltrates are seen. Sheets of foamy macrophages having abundant pale granular eosinophilic cytoplasm with regular round condensed nucleus are seen. Few of these cells shows round concentrically lamellated intracytoplasmic calcification with target-wide appearance known as Michaelis-Guttman bodies. These all are the similar picture which are seen in the another field of the slide. So summary of the finding. Histiocytes with granular eosinophilic cytoplasm and dense mixed inflammatory infiltrate, lymphoid follicles, hyperplastic urothelial lining with focal microcystic changes, intracytoplasmic calcification within histiocytes known as Michaelis-Guttman bodies, no evidence of dysplasia malignancy in the section studies. My final diagnosis is malakoplakia in backdrop of xanthogranulomatous cystitis. Malakoplakia is due to defect in the host macrophages response to a bacterial infection, usually from gram-negative equally-formed bacilli. Histiocyte shows round concentrically layered intracytoplasmic calcification known as Michaelis-Guttman bodies. These all are the sites where we can see the malakoplakia. In bladder, it appears as multiple nodular thickening of mucosa with underlying stoma, commonly seen in the region of trigone. It may be associated with immune deficiency state. Microscopy shows commonly xanthogranulomatous picture with few foamy macrophages showing abundant granular eosinophilic cytoplasm with MG bodies. MG bodies are positive for PAS, cysteine, and iron and calcium. Thank you.
Thank you, Dr. Ankita. Please stop sharing. I request Dr. Hemlata Madam to take
Yes,
it.
sir.
So please click on share screen and the entire screen and then open the PowerPoint.
Yeah, we are doing Aditya.
Yeah, Agatha. Is it visible? Now it should be visible.
Is it visible?
Yes,
Am I
ma'am.
audible?
Yeah.
Yes, please go. Please go. Thank you.
Okay.
Yes.
Ankita, it was very good presentation and it was
Yes,
indeed a correct diagnosis.
Thank you,
Okay, I'll just
Thank you,
go
ma'am.
into finer details of the case as well as little more in depth about melcoplakia. The case history given was 60 male who presented to the Department of Urology, and chief complaints were dysuria and frequency of almost 1 month duration, and there was no history of hematuria, fever, flank pain, or suprapubic pain. And previous history, the patient was non-hypertensive, non-diabetic, and there was no history of intake of any immunosuppressive drugs. Physical examination, all findings were within normal limits. I mean, no abnormality detected. Plus investigation, CBC, RFT, and electrolytes, T3, T4, TSH, all were normal. And they also ruled out diabetes because HbA1c was 5.7%. And with the symptoms, the clinician diagnosed the case as bladder tumor, query TCC, and posted for cystoscopy and transurethral resection of biopsy tumor. Bladder tumor. Operative findings on cystoscopy, they saw 4 into 3 centimeters growth in the anterior wall of the bladder, along with diffuse lesions all over the bladder. And they took biopsy from the primary growth as well as from the other lesions. And we received multiple irregular gray pink to gray brown tissue bits together amounting to 5 cc, and entire tissue was processed. And second container had 2 bits, larger measuring 1 into 0.5 centimeter, smaller measuring 0.3 by 0.3 centimeter. Both were processed entirely. Coming to microscopy, Ankita has already shown multiple bits, some having intact urothelium, some showing ulceration, some had thinning of the urothelium. But important lesion was seen in the lamina propria, which showed sheets of histiocytes admixed with other inflammatory cells, which are better seen in a higher power. Basically, we had neutrophils, lymphocytes, plasma cells, and predominant cells were histiocytes, which had foamy or lightly eosinophilic to eosinophilic granular cytoplasm with centrally located, unremarkable or vesicular type of nuclei. And the arrow shows aggregates of neutrophils which formed neutrophilic abscesses at place. And in Ankita's picture, we could see lymphoid follicles along with prominent germinal centers, and lamina propria did show edema and prominent blood vessels. And this is higher power to show the histiocytes, which are basically referred to as von Hansemann cells. They have abundant pale to eosinophilic cytoplasm and admixed centrally located nuclei, along with they were admixed with other inflammatory cells like neutrophils, lymphocytes, and plasma cells, with formation of lymphoid follicles at places. And also seen is overlying urothelium, which appears normal in this slide. And little more higher power, we could see the diagnostic or pathognomonic bodies, which are referred to as Meckley's-Guttman bodies, which are shown in the arrow. Some just looking like one dot, some are looking like a ring, some are proper targetoid or bullseye appearance, which have basically undergone mineralization with calcium and iron. Okay, they are also referred to as MG bodies, which are pathognomonic of melcoplakia. This is again one more picture. The arrows basically depict the Meckley's-Guttman bodies. and few more pictures to show the McLeish-Guttman bodies. And these were the special stains which can be used, which were used, and they highlight the MG bodies with Wonkosa, that is calcium will give black appearance, and the arrow shows typical targetoid appearance of the MG body. And we also did some other special stains like Prussian blue, depicting the MG bodies which have taken the blue stain, and past stain also was positive. And responses received, we received, and most of you have done diagnosis of melanoplakia. Along with that, some of the responders have given DD of follicular cystitis, maybe because some of the bits did show lymphoid aggregates with germinal centers, but that is one of the known feature in melanoplakia. We don't have to specify as follicular cystitis. The other DD was granular cell tumor. I'll discuss later, and invasive urothelial carcinoma and urothelial clear cell carcinoma were other DDs. And the final diagnosis in our case was melanoplakia, which was involving the urinary bladder and was mistaken as malignancy both clinically and cystoscopically. So coming to melanoplakia, it was first described by McLeish and Guttman in 1902, later named by von Hansemann. And this melanoplakia, the word comes from Greek. Melakos means soft, plakos means plaque. And it is considered as chronic inflammatory disorder of unknown etiology, and most commonly seen in patients who are immunocompromised, that is diabetes or renal transplant recipients, and people have even reported in patients with lymphoma or leukemias or any other malignancies with, and patients on steroids, and it can affect all age groups and peak in seen in 5th to 7th decade. Coming to prevalence, it's more commoner in females as compared to males, 4 times higher in women. And sites, most commonly encountered site is genitourinary system. In that, most common involvement is seen in bladder, followed by renal parenchyma, prostate, rarely ureter. Also, other reports, other people have reported melanoplakia in other sites like GIT, skin, thyroid, testes, lung, retroperitoneum, adrenal gland, cerebrum, vertebrae, pleura, tonsil, spleen. I think some even Ankita did mention. Coming to clinical features are non-specific. Most of the time, patient present with symptoms of cystitis like frequency, dysuria, hematuria, flank pain, or lower abdominal discomfort. And etopathogenesis, as I told, is unclear. Possible causes of infectious etiology and commonest bacteria causing melanoplakia is E. coli, along with other gram-negative bacteria. And plus there is defective macrophage function which fail to digest the bacterial debris completely, resulting in collection of these foamy or acidophilic macrophages, which are called von Hansemann cells. And over a period of time, the bacterial debris get mineralized by calcium and iron, and resulting in the pathognomonic or diagnostic feature of melanoplakia, that is McLeish-Guttman bodies, which will have halo also around. And cystoscopically, the lesions are seen as yellow tan plaques or nodules, which can vary in number and size. Some of them can be ulcerated, some can have central umbilication, and many times the lesions are confused with carcinoma. And for diagnosis, you need to have histopathology. So, in brief regarding melanoplakia, some books have given 3 phases, that is early, classic, and fibrosing. The lesions mainly involve lamina propria, and you'll see sheets, diffuse sheets, vaguely forming nodules of histiocytes called von Hansemann cells, and some of these histiocytes do show intracytoplasmic basophilic inclusions called McLeish-Guttman bodies. These intracytoplasmic inclusions are seen as small dots with clear halo around and are PAS positive in early phase, basically representing undigested bacteria. Okay, later phase, that is in classic phase, as these get mineralized with iron and calcium, the stains for iron, that is Prussian blue, and stains for calcium, oncosa, will stain these bodies, and they typically look like targetoid or bullseye appearance. And histiocytes may be surrounded by lymphoid aggregates with or without germinal centers. Maybe one of the reasons why people have given diagnosis of follicular cystitis. Overlying urothelium may be ulcerated, hyperplastic, or metaplastic, but it doesn't show any in situ or dysplasia, ruling out urothelial carcinoma. And treatment, you have to give long-term antibiotic treatment. If doesn't respond, then you have to do surgical resection. Coming to DD, as I said, one of the DD was granular cell tumor. Yeah, it is one of the close DD, but the granular cell tumor is extremely rare in bladder because common site is head and neck. And you all know it arises from nerve sheath cells, specifically Schwann cells. So on immunohistochemistry, the granular cell tumor will be positive for S100, whereas melanoplakia is negative for S100, and you won't see the pathognomonic or diagnostic Mecklis-Gutmann in granular cell tumor. So other DDs were like urothelial carcinoma, to be specific, poorly differentiated lymphoepithelioma like or plasmacytoid variant of urothelial carcinoma may be mistaken for melanoplakia, but however, the nuclear features, the nuclei will show pleomorphism plus overlying epithelium do show dysplasia or in situ lesion, and further, you can confirm by doing IHC, that is CK, P63, GATA3, which will be positive in case of carcinoma and negative in case of melanoplakia. Okay, finally, take-home message is can be mistaken clinically and with cystoscopic findings may suggest carcinoma or may mimic carcinoma, and histopathology is diagnostic, which shows sheets of eosinophilic or lightly eosinophilic histiocytes called von Hansemann cells, along with intracytoplasmic inclusions referred to as Mecklis-Gutmann bodies, which are diagnostic. Thank you.
Thank you, ma'am. I now invite Dr. Rajesh Prakash to present S6.
Yes, sir. I will do that.
Please share your screen, Rajesh. And then,
Yes, sir. Am I audible, sir? Hello?
Yeah, you're audible.
Sir.
You're audible.
put it on slideshow mode.
Can I start now, sir?
Put it on slideshow mode first.
Okay.
Go ahead.
Is it okay?
But I have to be here. You can go in the
Shall I begin, sir?
Dr. Rajesh, please start.
Yeah, we can start. You can start.
Good afternoon, everyone. This is Dr. Rajesh Prakash, first year postgraduate from Department of Pathology, Basaveshwaram Medical College and Hospital, Chitradurga. The case that we have been assigned is case number S6, and the case history is as follows. The patient is 47-year female. She is a known case of retroviral disease, presented with intermittent fever and flank pain since 3 months, which indicates from immunocompromised state. CT abdomen revealed a hypodense mass in the upper pole of the right kidney, neoplastic query, and very infectious etiology. Nephrectomy done, slice for interpretation. This is the whole one view of the section. From here, what you can interpret is the most of the tissue is being necrosed, and there is only viable tissue at bottom of the slide. At low magnification, extensive necrosis of renal tissue is shown here, We can see glomerulus and partially throat necrosed tubules and all. At high magnification, renal tissue with extensive coagulative necrosis is seen. Outlines of glomeruli and tubules are maintained here. We can also see tiny specks of calcification. Numerous broad aseptate fungal hyphae with branching hyphae can be seen here. You can observe it here also, and in this picture also you can be observing here. This is the broad aseptate fungal hyphae branching, which is morphologically resembling mucormycosis. This picture here depicts angioinvasion of the fungal hyphae. This is the arterial wall that we can see, and the fungal hyphae is seen invading into the blood vessel. This is the glomerular invasion. Plenty of hyphae can be seen here. It is seen here in the basement membrane also and in the capillary walls also. At the viable tissue area, chronic inflammatory cell infiltrate is seen. It is composed of lymphocytes, histiocytes, and giant cells. These are the blood vessels seen in the viable area. Endothelial cells are seen here with plump endothelial cells without any viral inclusions. To summarize, 47-year-old female patient, known case of retroviral disease, presented with intermittent flank fever and flank pain since 3 months. Renal tissue showed extensive cortical necrosis along with mucor-like fungal hyphae showing angioinvasion, glomerular invasion. Histological findings are consistent with renal mucormycosis in a immunocompromised patient. Final diagnosis is features are consistent with renal mucormycosis. Thank you.
Thank you, Dr. Rajesh. Please stop sharing the screen.
Hello, Aditya. We have a small quiz in between by the time the next person gets ready.
So this case has to be discussed first, and after that we'll have this.
Okay. Because I think we have 5 of those.
Okay. Anytime.
Just put in the first one.
Done.
Anyway, answers.
I'll start the poll for that then. If you share.
No, no need for poll. Just a one-line answer. No need for
Done.
poll.
Okay. Thank you.
Okay.
So request all the audience to respond in the chat box to the answer that will be shared for this quarter now, before we discuss S6.
So respond to the spotter. It's critter time. You know what's a critter? Please. This is not the first question.
So please share the screen.
Yeah, just a moment. Yeah. Okay, this is not the first question. Okay. So the question goes here. You just have to spot the organism.
Request audience to respond in the chat box.
Audience can respond to the short chat box. It's just a spotter. It will be there for 10 seconds. And then the discussion will be starting. I'll stop. Okay.
All the responses are KBs, sir. So,
Okay. Very good. I'll put the answers later. And the use is open. Which one? Yeah.
Good afternoon, everyone. Can you hear me? Am I audible?
Yes, ma'am.
I'm Dr. Anita, Assistant Professor, KIMS, Bangalore. So Dr. Rajesh has presented very well, and his diagnosis is also correct. So it's now easy for me to quickly go through the slides. So
Okay.
case history, it was given as 47-year-old female, known case of retroviral disease, who presented with intermittent fever and flank pain for 3 months. CT abdomen showed hypodense mass in the upper pole of right kidney, neoplastic, very infectious etiology. Nephrectomy was done. So we got these are the responses that we received, and most of you have got it right as renal mucormycosis, and it was a straightforward slide. However, I will discuss the other differential diagnosis which I have received. So moving on to the investigation, the peripheral smear of the patient showed normocytic normochromic anemia with leukopenia. RFT was normal except for mild elevation of serum creatinine. DMSA shows renal cortical scan. DMSA renal cortical scan showed global cortical dysfunction. So this is the CT abdomen of the patient, and this is the right kidney, which is showing the hypodense mass in the upper pole of the kidney. And this is the cortical scan, which is showing increased renal uptake, increased tracer uptake. So gross, we received a right nephrectomy specimen measuring 13 into 6 into 3 centimeter with intact capsule. And on cut section, we can see gray yellow tissue, which is measuring 5 into 3 centimeter in the upper pole of the kidney. So microscopy, in this field, we can see the infarcted tissue here, and which is rimmed by granulomatous inflammation with foreign type of multinucleated giant cells over here. So higher power shows the same. Here is the infarcted tissue with foreign body giant cells and granulomatous inflammation. So another field, here what we see is the infarcted area. Within the infarcted area, we can see these fungal elements here. So all these are the fungal elements, which was also highlighted by Dr. Rajesh. So higher
Yes,
power
ma'am.
of it, how does it look like? So these look like broad, they're very broad, aseptic, they
Aseptic,
do not have any, hello, yes?
aseptic fungal hyphae.
Yeah, aseptic fungal hyphae with right angle branching, which is seen in the infarcted region. So this is the other image which is showing angioinvasion. So we can see the blood vessel wall, and within the wall and the lumen, we can see the fungal elements. So then we did a PASTIN. PASTIN highlights the fungal elements as magenta colored structures against the light pink background. We also did GMS stain. GMS stain also highlights the black stain fungal elements against the green background. So this image shows again angioinvasion by the fungal elements, and this is the higher power of the same. So the diagnosis is mucormycosis with infarction of right kidney. So renal mucormycosis, it is a very rare, life-threatening, angioinvasive, opportunistic fungal infection of the kidney. It is generally seen in immunosuppressed patients. It is caused by saprophytic fungi of the order Mucorales, subphylum Mucormycotina. It is generally present in soil or decaying plant and animal matter. Mode of transmission most common is aerosol. However, even percutaneous exposure or ingestion can also be the other modes of transmission. Risk factors includes diabetes mellitus. In our case, HIV positive patient, even that includes patients with hematological malignancies, or solid organ transplant recipients. All these people are risk factors for mucormycosis. It has a very poor prognosis with significant mortality rate. The clinical presentation can be classified based on the anatomical location. Most commonly, it is rhinoorbital cerebral mucormycosis, which is seen in India, followed by that pulmonary, cutaneous, GIT, disseminated, and it is very rare for isolated region mucormycosis. Pulmonary is most commonly seen in developed countries. Cutaneous mucormycosis, the risk factor is nothing but road traffic accidents or IV. This isolated renal mucormycosis patients generally present with pyelonephritis-like symptoms, which is nothing but fever, flank pain, dysuria, hematuria. So moving on to the pathogenesis, the fungus reaches the kidney through blood from pulmonary or GIT focus. Primary in kidney is very rare, and that spread, it is usually through local spread, ascending UTI infections or catheterization. So mucorales exhibit trophism from blood vessels, so they invade the endothelial cell and cause inflammation resulting in vasculitis. Damage to the endothelial cell will result in exposure of subendothelial collagen and aggregation of platelets resulting in thrombosis. So this in turn causes infarction and necrosis, and at this point of time it impairs the antifungal penetration. So moving on to the morphology, grossly you will see enlarged congested kidney, wedge-shaped cortical infarcts, areas of hemorrhage and necrosis can be seen, and this may mimic tumor. So microscopy, we see broad aseptate ribbon-like hyphae with right angle branching, extensive vascular invasion, necrosis, and it shows positive for PAS and GMS stain. So ancillary test, KH mount shows broad aseptate hyphae. Culture shows rapidly growing moles, so they grow within 24 to 48 hours with aerial hyphae, or they're also called as lid lifters. That's because these fungal organisms grow very rapidly, and if the lid of the petri dish is not closed properly, they lift the lid, and that's why it's called as lid lifters. However, the sensitivity for culture is less because of fragile fungal hyphae. Histopathology examination is the gold standard diagnosis. PCR can also be done. So treatment, surgical debridement, nephrectomy, and antifungal therapy. So I have just listed the other necrotizing renal lesions, and one of our responser had also told renal aspergillosis. How do we differentiate? Even in case of renal aspergillosis, which is very rare, we see coagulative necrosis. However, the fungal organism, how do they look? They look very narrow, septate hyphae with acute angle branching. Whereas in mucormycosis, we see broad aseptate hyphae with right angle branching. So Candida pyelonephritis, in this we will see yeast and pseudohyphae with surrounding necrosis. In case of renal tuberculosis, we can see granuloma with central necrosis and Langhans type of jade cells. In case of renal infarct, we see coagulative necrosis. Acute pyelonephritis, we can see neutrophilic infiltrate along with tubular destruction. Xanthogranulomatous pyelonephritis is also one of the differential diagnoses given. Here you will see foamy histiocytes, granuloma, and necrosis. However, we will not see the fungal elements. So take home message, this mucormycosis carries very poor prognosis and significant mortality rate. Successful management depends on high index of suspicion with early recognition. So histopathological examination is the gold standard for diagnosis. So whenever you're seeing a necrotizing renal lesion, first think of mucormycosis, and you have to look for vascular invasion and areas of infarct. Thank you.
Thank you, ma'am. I think with that, we can move to case number D4.
Yeah.
It will be presented by
I'll just,
Dr. Sitara KVG Surya.
yeah, Sitara, just be ready. I'll just post one more question of our quiz. Oh, this was the answer for the previous one. Is my slide visible?
Yes, it is.
Yeah.
It was, now it's stopped sharing.
Hmm. Now it's stopped.
Yeah, we are no longer able to see it.
Yeah, are you seeing the slide or not?
No, not yet. Not now. See.
Not yet. Okay. So this was the answer for the previous one. So most of them were right.
Scabies.
Scabies with the ala in the epidermis. This is the next one.
Requesting the audience to respond in the chat box.
Yeah. I'll read it later. It will be there for 10 seconds before the next person starts presenting. Time's up.
Dr. Sitara, I think you can share your screen now and present.
Yeah.
Before.
Good afternoon. I, Dr. Sitara Siddhi, finally a postgraduate, KBG Medical College and Hospital, Surya. The case allotted for me was case number D4A, 55-year male presented with lump in the left breast since 2 years. On examination, lump measured 3 into 3 centimeters, non-tender, partly mobile. Clinical diagnosis was gynecomastia. FNAC slides and excision biopsy slides provided. The FNAC slide is a moderately cellular smear with spindle cells having blunt, uniform, elongated nuclei with fine chromatin and scant cytoplasm. No atypia or mitosis. Mature adipocytes which are scattered singly and in small clusters. Background shows fibrillary collagen fragments and mildly myxoid, and few bare nuclei were seen. So this is a FNAC spear, which is one is PAP stained and the other one is MGG stained, showing moderately cellular smears with spindle cells having bland, uniform, elongated nuclei with fine chromatin and scant cytoplasm. Also seen are mature adipocytes scattered singly and in small clusters. Background shows fibrillary collagen fragments and bare nuclei. Biopsy slide shows HND stained section showing a benign adipocytic neoplasm with bland spindle cells and hyalinized rope-like collagen fibers with scattered mast cells. Spindle cells are arranged in fascicle, storiform, and whorl pattern in a fibrous myxoid or collagenous stroma. No necrosis marked cytologic atypia or mitosis. Summary: FNAC smear with mature adipocytes, uniform spindle cells in a myxoid background. Biopsy shows mature adipocytes with bland spindle cells and ropey collagen. With all these findings, we came to the final diagnosis of spindle cell lipoma. Further evaluation is by immunohistochemistry. CD34 strongly positive in spindle cells, which is negative in case of myxoid liposarcoma. S100 negative in spindle cells but positive in adipocytes. STAT6 negative to rule out solitary fibrous tumor. Case number D4B, 32-year female with lump in the right breast since 1 year. FNAC Yokohama C2, excision biopsy slides provided. The biopsy microscopy, biopsy shows lobules of normal breast glands, oddly arranged or distorted. Fibrous stoma with few areas are hyalinized. Mature adipose tissue interspersed with ducts and lobules. No significant cytologic atypia or mitosis. And focal area shows mild epithelial hyperplasia. HND stain section shows small round to oval glands or ducts infiltrating fatty and fibrous stroma, lined by single layer of cuboidal to flattened epithelial cells with small nuclei and amphiphilic cytoplasm. The glands contain eosinophilic secretions, preserved basement membrane, and intact myoepithelial cell layer. Summary: benign ducts or glands lined by single layer of cuboidal cells, intact basement membrane, and myoepithelial cell layer. No significant nuclear atypia. Fibrous stroma interspersed with mature adipose tissue and congested blood vessels. Differential diagnoses were mammary hematoma and microglandular adenosis. The characteristic differentiating features between mammary hematoma and microglandular adenosis are: mammary hematoma is a benign lesion with a disorganized normal tissue, whereas microglandular adenosis is benign but neoplastic and infiltrative. Mammary hematoma, the myoepithelial layer is present, which is confirmed with the myoepithelial markers P63 and SMA, whereas it is absent in microglandular adenosis. S100 is usually negative for mammary hematoma, but it is strongly positive in epithelial cells. No risk of malignancy in mammary hematoma, but microglandular adenosis, there is a precursor to triple negative carcinoma. Thank you.
Thank you, Dr. Sitara. Back to Tejasvi sir for the discussion.
Thank you, sir.
Tejasvi sir. Tejasvi sir, over to you.
Yeah.
Your video is shift. switched off.
Video is shut. Yeah, I'll switch it on. Stop sharing.
Good afternoon, one and all. I'll start discussion of slides number 4A and 4B. As Sidara has already presented, it was a male patient, 55-year-old. The lesion was present from past 2 years, measuring approximately 3 by 3 centimeters, non-tender with limited mobility. So clinically, it was diagnosed as gynecomastia. FNAC was subjected, and we have also provided the FNAC slides. As you can see, and you have already seen, the slides are quite cellular, comprising predominantly of spindle shaped cells, and there were no ductal elements seen in any of the slides. And different magnifications are seen in this image. The spindle shaped cells, these spindle shaped cells having moderate amount of cytoplasm, elongated oval nuclei, inconspicuous nucleoli, focal nuclear atypia can be appreciated in some of these slides. Okay, focal nuclear atypia is seen, and higher magnification, nucleoli is seen, small distinct nucleoli, mild nuclear pleomorphism. With all these, the diagnosis of spindle cell neoplasm with focal atypia was given. Because it was a male, 55 years of age, and the duration of the lesion was for 2 years, and the mobility was restricted, and the clinicians went ahead and they did simple mastectomy along with the nipple areolar complex, which we received in our pathology section. The skin nipple area complex appeared completely normal. And this lesion, as you can see, after cut section, you can see a well circumscribed solid tumor. You can see how well neatly circumscribed. It could have been easily enucleated. It looks like that. So it was located in the upper inner quadrant of the breast and measured 4.2 by 4 by 3 centimeters. All the margins were free, the closest margin being 1.2 centimeter, the superior margin. Now, microscopy, Sitara has shown all the good images of that. I am just showing some of those. As you can see here, you are seeing mature adipose tissue, yes. Then there are fibroblasts, the spindle-shaped cells arranged haphazardly at places. And focally here in this corner, you can see some amount of mixed edematous stroma. So other than the spindle-shaped cells, you can see this bright eosinophilic collagen bands. Okay, thick hyalinized collagen bands are seen. Now, further higher magnification, these collagen bands are well visualized. Can you see in all these 3 images? And the bland spindle-shaped cells arranged in short intersecting fascicles having bland oval nuclei. Now, this, as Sitara has discussed, there are quite a number of differentials with only histological sections, that is only based on H&E stain. There are a lot of spindle cell neoplasms which come into the differentials. Without IHC, it is difficult to do. So which we went ahead and did markers for Desmin and CD34. Both came strongly positive. Then beta catenin was negative. So we made final diagnosis of myofibroblastoma lipomatous variant. Sitara also made a diagnosis of very close differential, that is spindle cell lipoma. I will discuss the differentials. Now, various differentials received are, that's why I put as differentials, myofibroblastoma, fibromatosis, PASH, spindle cell lipoma, spindle cell neoplasm. Some of them have given the DD as malignant phyllodes and polymorphous carcinoma of the breast. Maybe this was thought of based on cytology slides. Now coming to the differentials one by one, fibromatosis. Fibromatosis grossly presents as a stellate mass, not as a well circumscribed mass. It is also comprised of spindle-shaped cells of fibroblasts, which are arranged in broad bands, unlike in our case, which is short intersecting fascicles. Here the collagen may be abundant. Sometimes the collagen can be so abundant that it can look like a keloid or desmoid variant of fibromatosis. and it has shows infiltrating edges. Unlike our case, which has well circumscribed, the cells can show infiltration into the adjacent breast tissue, to the adipose fat tissue, or even to the chest muscles. Now, IHC will help in differentials. Beta catenin will show diffuse and strong nuclear positivity in case of fibromatosis, and it will not be there in case of myofibroblastoma. CD34 will be negative here. The other DD was PASH. PASH, as the name suggests, it is pseudo-angiomatous stromal hyperplasia, which means it has a slit-like vascular spaces which looks like vessels, but they are not actually vascular spaces. The line, the endothelial-like lining of cells are nothing but the myofibroblasts. And PASH is a very common diagnosis on gynecomastia. Almost 40 to 43% of gynecomastia cases which have been excised turn out to be PASH. The PASH has one more variant, fascicular PASH. Only that I'll be touching upon, not the other variants. This fascicular PASH has more spindle cell rich, so that is more likely to be mistaken for spindle cell neoplasm. So assume whoever has posted the DD as PASH might have thought of as fascicular PASH as the DD. But extensive bitting will reveal that some conventional PASH-like areas will be seen with areas of ducts, lobules at least at the margin of the lesion. And this will be positive for CD34, vimentin, and actin. Now, coming to the most important differential diagnosis, that is spindle cell lipoma. Spindle cell lipoma, most of you would have thought of, yes, it can be still a differential diagnosis. It is a rare variant of benign lipoma of the breast. And spindle cell lipomas occur in other soft tissues. Also, it can occur in the breast parenchyma. If it occurs in the breast parenchyma, males are more likely to be affected, 100 times more commoner than females. In our case also, this is a male patient. Okay, so it has a admixture of mature adipocytes, spindle-shaped cells which are bland looking, and ropey or thick hyalinized collagen fibers. All these three elements are seen in our case also. So now IHC is positive for in spindle cell lipoma. CD34 vimentin may be positive, negative for desmin, smooth muscle actin. Our case, as you can see, it was positive for desmin in addition to CD34. Now coming to the discussion, our diagnosis being myofibroblastoma, it is a benign mesenchymal neoplasm comprising of fibroblast and myofibroblast, the common site being breast as well as extramammary tissues in the form of inguinal, vulva, perineum, and scrotum can be involved. It usually presents as a well circumscribed, lobulated, homogeneous solid mass. Our case also, it was well circumscribed with homogeneous solid gray white mass. Age, elderly men or postmenopausal women, again the age fits in. So the size approximately is 3 centimeters, comprising of spindle shaped cells in haphazard or short intersecting fascicles. This was also, we have shown the images. Nuclei, the spindle cells having bland oval nuclei, yes, interspersed hyalinous collagen bundles. Mitosis were not there, so mitosis can be very few or very, very rare. So all these findings were seen in our case also. And this has classically 5 patterns: the lipomatous pattern, myxoid, fibrous or collagenized, epithelioid or deciduoid, palisading or Schwannian-like patterns are described. And ours, we thought, because there was good amount of mature adipose tissue, it was considered as myofibroblastoma lipomatous variant. Now, one more thing about myofibroblastoma is, what is the origin of this tumor? It originates from a precursor cell which can differentiate along either lipomatous or leiomyomatous tissue. So all of you know the precursor cells have plasticity and can differentiate along various cell lines. And another interesting feature about this is presence of 13q deletion and monosomy of 16q. 13q deletion is associated with the loss of RB1 expression, as can be detected on IHC. And FISH can be done for its diagnosis, which shows 13q14 deletion. And these tumors, the myofibroblastoma, the spindle cell lipoma, or cellular angiofibroma, all these come under the family of 13q-RB family of tumors. So spindle cell lipoma, the Sitara has made diagnosis. Yes, it is a very close differentials For this, we have made the diagnosis of myofibroblastoma lipomatous variant. Now, case 4B, the second half of the same thing. This is a female patient presenting with right breast lump of 1 year. FNAC, it was said that it is a benign lesion. Excision biopsy was done and the slides are provided. Now you can see the specimen neatly circumscribed. So they have just done the specimen well circumscribed lesion which has been excised here, which is measuring approximately 5 by 4 by 2 centimeters. The cut section, as you can see, is solid, predominantly yellow. It looks like as though it is a lipoma, correct, with some focal gray white areas which can be seen here and there. Now, microscopy, well circumscribed lesion, you can see there is abundant mature adipose tissue is seen, plus there are mammary lobules here, they're scattered with intervening stroma there. Now again, these mammary glandular tissue or well circumscribed lobules are seen. The lobules appear completely normal, as though it is like a normal breast parenchyma, except for few dilated ducts here and there. The rest of the breast parenchyma appears normal with well circumscribed lobularity is being maintained, and the intralobular stroma is fibrous, and at places these mammary lobules are surrounded by fibrous tissue, or it may be just merging with the adjacent fat. So there are three components. There is fat, there is mammary tissue, the lobules, they look normal. There is no proliferation as such. Okay, so here you can see delicate capsule with compressed parenchyma at the margins. There are no proliferative changes, and there is definitely bilayered epithelium which is seen in these lobules. Now, the final diagnosis with these findings, we made the diagnosis of hamartoma adenolipoma. I think even Sitara has made the diagnosis. The responses received are microglandular adenosis, sclerosing adenosis, tubular carcinoma, and fibroadenomatosis. Microglandular adenosis and sclerosing adenosis. Microglandular, you will have proliferation of the tubules, very, very important. To say adenosis, there will be extensive proliferation, not the normal or atrophic breast parenchyma should not be seen. And here you will not see the neat lobular outline as we are seeing in our case. It will be more haphazard arrangement, and it will be have single epithelial cell layer with absence of myoepithelial cell layer. Most of the lobules and ducts, they showed bilayered epithelium. Even Sitara pointed to some of the myoepithelial cells in her images. Microglandular adenosis can show positive secretions in the lumina. So here in our case, there was no lobular outline. There was no proliferation of the tubules. Tubules, mammary lobules were completely normal, and there were bilayered epithelium. So this doesn't come into the diagnosis. The sclerosing adenosis is more of architectural diagnosis, wherein you will see in the center of the lesion showing extensive fibrosis and compressed and distorted tubules. They'll have bilayered epithelium. There can be peripherally proliferation of the myoepithelial cells forming sheets and cords. Dense hyalinized fibrous stroma will be seen in case of sclerosing adenosis. Then tubular carcinoma, I think one of the DD was tubular carcinoma, which we got the responses. Tubular carcinoma is irregular, angular outline, is set in a dense cellular stroma, and there will be single epithelial cells. There will be absence of myoepithelial cells, and nuclear pleomorphism will be there. So tubular carcinoma will not come into it. Somebody had mentioned fibroadenomatosis. There also, it can have fibroadenoma-like areas with areas of epitheliosis and adenosis. Occasional ducts were dilated in our case, but other features were not fitting into that. Now coming to the discussion, hamartoma of the breast. This is considered, all of you know what is the diagnosis of hamartoma. Here it is called as breast in breast. This accounts for approximately 4% of benign breast lesions, occurring usually in the premenopausal age group, but it can occur in teenagers as well as elderly. It is a soft, palpable mass, solitary, usually solitary, but it can occur multiple, or it can come present in bilateral breast. So you have to consider Cowden syndrome. It has two variants. One is adenolipoma and chondrolipoma. I'll be only dealing with this one. So adenolipoma, age highly variable, mean age being, as I already discussed, the ages can be teenagers to elderly, 40 years. So pregnancy is one of the pregnant women, it is known to occur. So hormonal influence may play an important role in the pathogenesis. So our case also had lobulated soft mass within fibrous pseudocapsule, and it can be pink or whitish or yellowish depending upon the component of adipose tissue or fibrous tissue. So there will be admixture of all the three components: fat, fibrous tissue, lobules, which are normal or compressed. Okay. I think that's it. So there is this was a case of hamartoma of the breast. Thank you.
Thank you. So would you like to show the answer to the previous critter?
Yeah. Just a second.
Meanwhile, I request Dr. Vasundhara to be ready to share the next case, which is the D6. Dr. Vasundhara is from KIMS Manipur. You may unmute yourself, Dr. Vasundhara.
Yes.
Yes, just hold on, Dr. Vasundhara, and we will get back to you immediately after Sir shares the diagnosis for the previous quarter. Tejasvi, sir, over to you. Tejasvi, sir, you're muted. Tejasvi, sir, you're muted there. Some technical issue. I think Dr. Tejasvi sir will be back soon. Just please hold on.
Yeah, I'm back, Aditya. Some glitch. I'll share the screen now. The answer for the previous one. Okay. So your answer is visible actually when I just started sharing. So this is the answer for the. I think one or two have got it right in the chat box. Yeah. All I think one. This is a. Actually, Shruti ma'am diagnosed this. She can take over and tell a few things about sarcina ventricular.
Am I audible?
Yeah. Yeah, go ahead.
Yeah, so sarcina is a bacteria which is usually seen in patients with gastric outlet obstruction. It's a rare bacteria. Now, whether it is pathogenic or not, that's under debate. Some say it's an incidental finding, some say it can lead to gastric perforation. So I think if you have a keen eye for these organisms, you can pick it up. They mostly appear as tetrads and octets.
That's indeed a rare one, ma'am.
Yeah.
For you to pick up. I think with that, we'll move to the next case presentation by D6 by Dr. Vasundhara from KIMS Manipur. Vasundhara, you may unmute and
Stop sharing.
Share your screen.
Sir, is it visible?
Yes, please go ahead.
Good afternoon, everyone. My name is Vasundhara. I'm a third year PG from KMC Mangalore. I'll be presenting the case D6. So this is a case of a 50-year-old man who is a known case of scleroderma crest syndrome. He presented with complaints of painful swelling over the left nostril since the last 6 months. The swelling was progressive in size and blackish in color. He also had a previous history of a nasal vestibular abscess for which incision and drainage was done. And now the excision biopsy of the swelling has been sent. So this is how it looked like. So as we can see here, there is epidermis here with stratified squamous epithelium. And from the dermis, there is diffuse dense infiltration of these proliferating cells, which are all blue in color, and they're going very deep from the superficial dermis. In the next slide, we saw there is nasal cartilage here, which is also surrounded by these cells. They are not infiltrating inside the cartilage, but they're surrounding it. And there is a very characteristic dilated blood vessels and a lot of intratumoral hemorrhage seen as well. And when we shift from scanner to low power view, we saw that these cells were arranged in diffuse solid sheets, lobules, as well as nets. In fact, they also formed some anastomosing trabeculae at places. On high power, we can see that the epidermis is intact, there's no ulceration, and there's no dysplasia as well. The stratified squamous epithelium, it is not involved by the tumor cells, although the cells are quite close to the epidermis, but they're not involving it. And there are a lot of dilated blood vessels here seen, which are surrounding the epidermis. Now, as we look at the cells are small to medium in size. They are very atypical and they have this plasmacytoid appearance and also epithelioid-like appearance. They have a hyperchromatic nuclei. In other places, there is a very different morphology. Here, these cells have pale eosinophilic to clear cytoplasm with high NC ratio here, as you can see. These nuclei are round to oval. They have irregular nuclear contours, and also there's vesicular chromatin, as well as a very prominent central nucleoli. Here as well, this is the same morphology as you can see, along with multiple dilated blood vessels scattered throughout the tumor. Here there was karyorectic neutrophilic debris, which was surrounded by the tumor cells here. Also, a lot of areas of complete extensive necrosis in the tumor was seen. And there was brisk mitosis in the tumor. Some of these mitotic figures were atypical. So considering all these points of a diffuse dermal tumor forming sheets of cells with varying morphology of very high-grade appearance, I gave an impression of poorly differentiated malignancy with the following differentials. Now, my first differential was mucosal malignant melanoma. Since the swelling was pigmented, progressive swelling with nasal cavity is the most common site seen in mucosal melanoma. I could not find any melanin pigment there, but it seemed that these melanomas are approximately 50% are amelanotic. Although there should be abdominal involvement of angina, the cells are large epithelial to pleomorphic cells with prominent nuclei and brisk mitosis. My next DD I've kept as epithelioid angiosarcoma because it was a very black colored swelling with a lot of hemorrhage. So I've taken a vascular tumor. These present as painful cutaneous blue colored nodules and their appearance is widely pleomorphic. It's said that these cells can form sheets without formation of blood vessels and the vessels that are there, they should be lined by atypical endothelial cells. These kind of tumors, they completely destroy the dermis and they do not involve the epidermis. They show a lot of intratumoral hemorrhage as well as brisk mitosis. My next differential was nut carcinoma. Nut carcinoma, as we know, are midline carcinomas. So since this was actually on the left nostril, but there was a history of nasal vestibular abscess, so that might have been the tumor as well. So it is a midline exophytic mass, which is painful and very aggressive. The cells here are undifferentiated medium-sized cells, but these cells have vesicular chromatin and prominent nuclei. They are very monomorphic in appearance, and the ATPI is quite less. There is a very significant finding in nut carcinoma though, that is abrupt squamous differentiation, which I could not see here. There is also brisk mitosis and extensive necrosis. My next DD was sinonasal undifferentiated carcinomas. So these are also known as carcinomas of uncertain histogenesis. These are exclusion diagnosis. They are usually seen in people with 50 to 60 years of age with variable presentation, with the most common site being nasal cavity. They present as a fungating mass with ill-defined borders, and the appearance of the cells are highly pleomorphic with lobules and a lot of necrosis as well as brisk mitosis. The last differential I've kept as SW1 SNF complex deficient sinonasal carcinoma. Although this is a molecularly defined carcinoma, since even then it originates in the paranasal sinus with extensive aggressive nature as a polypoid mass, has a necrotic appearance, so it can give that brown black color also. The microscopy is why I have kept this as a differential, because they also have a plasmacytoid, rhabdoid, and epithelioid appearance, and the cells are arranged in trabecules usually, and they lack any kind of differentiation. So there's no squamous or granular differentiation seen there. There's a lot of mitosis and extensive tumor necrosis here as well. So with these differentials, I'd like to approach with IHC panel of these markers. First are for melanomas, I'd like to give HMB45, Milan A, S100 and PRAME. And the vascular markers, CD31, CD34, ERGM51, and Vimentin as well. Nut carcinoma, nut IHC has to be given. And for the last two differentials, PAN-CK, P63 and P40 can be taken. Now for the moleculars, also molecular analysis can help in, especially in that SW1 as fusion carcinoma. For that, SMART B1 and SMART A4 loss is indicated. And NUT carcinoma shows NUT M1 rearrangement and IDH mutation that is seen in sinonasal and differentiate carcinomas. So this is how I'd like to approach the case. Thank you.
Can you this? Am I audible? Escape madla. Yeah. So thank you, Vasundhara. That was a very comprehensive presentation, and I think you've discussed most of the differentials very well. So to start off with the case discussion, this was a 50-year-old male. He was a known case of scleroderma and Crest syndrome. So initially, he started off with a painful bluish nodule on the nose, which eventually progressed to involve the entire nose, as shown in the image. So before an excision biopsy was done, a PET scan was done where the findings were as follows. So they noted a soft tissue swelling at the anterior nasal septum, the tip, and dorsum of nose along the cartilaginous portions. They were preferring an infectious or inflammatory etiology over a neoplastic etiology. Patient also had multiple enlarged lymph nodes, both cervical, mediastinal, prevascular, internal mammary, and hilar nodes. He also had nodular pleuropulmonary opacities in both the lungs and a dilated esophagus. Following all this, an excision was done, and this is a specimen we received in the lab. So if you note, the size of the lesion was almost 5 by 5 by 4 centimeters approximately, and it was a nodular lesion with bluish black discoloration. The image on the right, it appears bluish black, and the glistening areas is it's nothing but the nasal cartilage. So sections were scanned and slides were posted, and these were the responses we received in chronological order. So moving forward to the microscopy.
So this is a scanner magnification of the whole slide image that was provided to you. We are seeing a squamous epithelium at one end and there's cartilage towards the other end. There's also nodules of tumor cells, nodules and cords of tumor cells, and we are also seeing plenty of blood lakes. A slightly higher magnification, again showing cords and nodules of these tumor cells, and what is very prominent here is the vascular spaces, all of which appear to be lined by plump cells, some more plumper than the other. 20x magnification. Image on the left, again it's showing vascular spaces which are lined by plump endothelial cells which are almost like protruding into the lumen. They have like moderate amount of eosinophilic cytoplasm and something like an epithelioid morphology. The image on the right side, what we are seeing here are ramifying vessels. Many of them are showing intraluminal or intravascular buds and multi-layering of these lining cells. Vasoformative areas were seen. This is a higher magnification. Again, vascular space is lined by atypical cells, many with intraluminal buds, multi-layering and papillations. Again, these nodules of tumor cells, these are showing like a sieve-like pattern along with intracytoplasmic lumina. Many of these lumina are showing RBCs. Cells were very pleomorphic with moderate amount of cytoplasm, vesicular nuclei, prominent nucleoli. They all have something like an epithelioid morphology. Mitotic activity was frequent. Atypical mitosis were also seen as highlighted in this image. There was erosion of cartilage and coagulative necrosis. A panel of IHC markers were done. So as you can see, the first marker listed here is pancytokeratin. Now the lesional cells were negative for cytokeratin, or the only positivity taken is by the squamous epithelium and the ethnic cell structures. So this rules out a carcinoma. S100, SOX10 were both negative for the lesional cells, which rule out a melanoma. Synaptophysin was also negative, which rules out a neuroendocrine carcinoma, which can also arise in the sinonasal tract. CD31 showed strong membranous positivity in all these lesional cells, and the tumor also showed a high proliferative activity of about 15%, which was highlighted by Ki67 IHC. So to summarize, what we are seeing are vascular channels, some of them ramifying, lined by atypical epithelioid cells showing intraluminal buds, papillations, and multilayering. Vasoformative areas were seen, blood lakes were seen, similar cells were seen in nests and cords. The tumor showed a high mitotic activity with large areas of necrosis as well as cartilage erosion. IHC CD31 showed diffuse membranous staining. Ki67 also showed a high proliferative activity, whereas the lesion was negative for pan-CK, SOX10, S100, and synaptophysin. Now, moving on to the responses received. So these were the responses that we received in chronological order. So let's just rule them out one by one. I think Vasundhara has already discussed most of these conditions. So we all agree that it's a neoplasm, which rules out all these three conditions. The second common response received was a melanoma. As discussed by Vasundhara, yes, most of the sinonasal melanomas are amelanotic, but again, vasoformative areas are not a feature of melanoma. Now, the bluish black discoloration, yes, it could either be melanin pigment or it could also be a vascular tumor, the gross discoloration. And these lesional cells, they do have vesicular nuclei with prominent nucleoli, but there are no vasoformative. Melanoma will not show vasoformative areas, and also the tumor was negative for S100 and SOX10. A bunch of other differentials included different types of carcinomas, which are all close DDs to one another. So all of these carcinomas have high mitotic activity and large areas of coagulative necrosis. And again, the IHC here showed negativity to pan-CK. Two lesions of special mention here Again, one is the SWSNF complex deficient sinonasal carcinoma. This is a category of, comes under the category of SMARCB1 deficient carcinomas. Here, what you mostly see are the tumor cells can show either a basaloid morphology, a plasmacytoid morphology, or a rhabdoid morphology. We did not see predominantly, most of them will show a basaloid morphology, which is not the feature here. And again, vasoformative areas will not be seen in this particular lesion. Nut carcinoma is another DD that is provided, wherein you see monotonous cells with vesicular nuclei and prominent nucleoli. And another important criteria for these lesions is presence of abrupt keratinization or squamous differentiation, which again is not seen in HND slides. The next DD is extranodal NK or T cell lymphoma. Here, what you're supposed to see is atypical lymphoid cells with scattered histiocyte-like cells, large areas of necrosis and mitosis. Probably one of the reasons this was given as a DD was because of its angiocentricity. These lymphomas are known to show angiocentric behavior with many vessels showing atypical lymphoid cells. But again, vasoformative areas are not a feature of these lymphomas and they will not show CD31 positivity. Carcinosarcoma can be ruled out for the same reasons. A very close differential that we received was epithelioid hemangioendothelioma. So these tumors are characterized by two main features. One is epithelioid morphology with vasoformative areas, which is seen in this particular lesion. However, they should have myxohyalin stroma, which is absent in the current case. And these tumors, they are mostly of intermediate grade. It's a vascular tumor of intermediate grade, but there are certain aggressive forms. About 15% of these are known to be aggressive. One important IHC marker that can be done is CAMTA1, which is positive in epithelioid hemangioendotheliomas. So with all these differentials that have been discussed now and all these morphological and immunomorphological features, a final diagnosis of epithelioid angiosarcoma was given. So just a few words about angiosarcoma. So it was first described in detail by Wilson Jones in 1964, commonly seen in the 6th decade. It accounts for 1 to 2% of all sarcomas, with the skin and superficial soft tissue being the most common location. And the commonest site in the skin is the head and neck area, mainly because of its vascular density and the frequent exposure to ultraviolet radiation. Etiology as such is unclear, but it is associated with various factors such as vinyl chloride exposure, chronic lymphedema, trauma, radiotherapy. And as in the current case, telangiectatic skin lesion can also be a precursor for development of angiosarcoma. We had already provided in the history that the patient has CREST syndrome and also scleroderma. So the clinical behavior, it has a very poor prognosis with a 5-year survival of about 30 to 50%. And the death is mainly due to metastasis to the lungs, liver, and lymph nodes. So the prognostic factors which can influence the outcome are as listed here. So age is an important prognostic factor, with 50 years being the cutoff. Those under 50 have a better prognosis as opposed to those over 50. Location and focality, head and neck tumors have a poor prognosis. Multifocal tumors have a poor prognosis. Clinical extent, metastatic disease, if at all it is present, carries a poor prognosis. The size of the tumor is another important prognostic factor, with 5 centimeters being used as the cutoff. A positive margin status is a poor prognostic factor. And on histology, they have certain studies have shown a risk stratification, where they said necrosis and epithelioid morphology indicates a high risk status. Staging of angiosarcoma, WHO does not recommend staging of angiosarcoma because no matter what the stage, these tumors are supposed to be aggressive. Treatment is surgical excision with adjuvant radiotherapy. Chemotherapy may be performed for metastatic disease. So what happened to this patient? He was given a customized prosthesis 10 days after surgery. 3 months after follow-up, he had 2 ICU admissions for generalized weakness and hemoptysis, and 4 months later, he succumbed to type 1 respiratory failure, secondary to alveolar hemorrhage and aspiration pneumonia. Thank you.
Thank you, ma'am. This is Fisa, over to you.
Yeah. So we'll go to the next one. Is my slide visible? Not yet, no? Is my slide visible, Aditya?
Yes, it is, sir. Yes, it is visible. Please go.
This is the next one.
The responses can be made through the chat box.
Yeah.
The answer will be shared after the
Because
presentation
we have
makes
to,
sense.
we are, I think, overshooting time. I'll just put the next one also after this, so that everybody can. This is the next one. This is the next one. So be ready with the answers. After the next 2 cases, or the next case, we will put another one, the last one. This one, this one. Next person is ready for presentation.
Dr. Madhurya from Subbaiah Institute Medical College, Institute of Medical Sciences, Shimoga. Request you to
Yes,
unmute
sir.
and present SQ.
Sir, am I audible?
Yes, you are. There is an echo, but
Is
please
it
ensure
echo?
that there's nobody else in the room with the same any other device on. Okay. Please share your screen, Madhurya.
Yes, sir.
Open your PowerPoint. Madhurya, please share your screen. Yes. Slide show more. Go ahead.
Yes. Good afternoon, everybody. I'm Dr. Madhurya, second year postgraduate from Subbaiah Institute of Medical Sciences, Shimoga. So the case allotted was S4 with a 78-year-old male presenting with right-sided chest pain and coughs in 15 days. CECT showed a well-defined enhancing mass in the upper lobe of lung, and the lung biopsy for interpretation was given as this. So it showed tumor cells that were arranged in cord sheets and trabeculae, as seen here on the low part. And the cells are pleomorphic with high NC ratio, hypochromatic nuclei, prominent nucleoli with nucleus pushed to the periphery, and the cytoplasm shows little clearing. And the other focus also showed tumor cells that were arranged in cords and sheets. And there were few nuclear inclusions that were seen, and a foci of necrosis was seen, as pointed out. So the microscopy was the biopsy that showed small fragments of tumor tissue that was composed of small round to oval cells which were arranged in sheets, nests, and trabeculae. These cells are pleomorphic with high NC ratio, hypochromatic nuclei, prominent nucleoli with nucleus pushed to the periphery, and the cytoplasm showed clearing. So there was a lymphoplasmacytic infiltrate that was seen, and also nuclear inclusions were seen with foci showing necrotic areas, and there was no evidence of keratinization, gland formation, or mucin production seen. So the diagnosis made was clear cell variant of large cell carcinoma.
Okay.
Thank you, Madhurya. Am I audible?
Yes, ma'am.
Okay. Thank you for that crisp description. I think you have brought up the history also. So 78-year-old male has complained of chest pain and cough since 15 days. And looking at the CECT findings, the patient had a well-defined enhancing mass in the apical segment of the right lobe, and it measured almost around 7 into 6 into 2 centimeters, with the ill-defined fat planes surrounding the pleura. An associated finding was destructive erosions of the right anterolateral aspect of the ribs, the second and the third ribs. Patient also had mild pleural effusion, which was aspirated and sent for cytology, which we could not find any atypical cells. So as you have seen, there are multiple fragments that we have received, multiple core biopsies that we received. So when we look at this core biopsy, predominantly we see that it is cellular with few hyalinized areas. Predominantly it looks a lot of blue areas, highlighting that the cells have a large nucleus. So on higher magnification, we see that the tumor cells are in sheets, and most of them were showing this plasmacytoid appearance, if we can call them, where the cells are having, they're pushed and they're having a slight perinuclear half, if you can observe here. And most of the cells are having clear cytoplasm. So I think that is also one of the reasons why few of you have made a diagnosis of clear cell variant of other tumors. Again, on higher magnification, it's highlighting the same. And some of the slides probably are showing the small, artifacts. So based on this, some of you also have made a diagnosis of pulmonary pencillosis. It's an artifact, and we have not seen any of those while observing in predominant part of the cells. And if you look at this section, mostly there are intervening areas of hyalinized collagen, but predominantly tumors are arranged in forms of sheets with few vascular channels in between, surrounding the vascular channels. But most of them are in sheets with plasmacytoid appearance, some having eosinophilic cytoplasm. You can see here with the perinuclear half, and many of them showing clearing or cytoplasmic clearing. So with this in mind, of course, you have made a diagnosis of carcinoma, which is very valid, because whenever something we see in the lung as a solitary lesion, the first diagnosis should be, we think of the common things first. So carcinoma is your first diagnosis, well appreciated. But if we take history with the CECT findings and the microscopic findings, probably we can come at a different diagnosis. So the responses received, many of them in chronological order, have made a small cell carcinoma of the lung, hyalinizing clear cell carcinoma, myoepithelioma, the plasmacytoid variant of adenocarcinoma, signet ring cell carcinoma, plasmacytic lymphoma, pulmonary pencillosis, and PCOMA. These were the differential diagnoses that we received. So as like you, we also suspected carcinoma. That was our first differential. So we got an abscin A done, which was negative. And generally, when we see these plasmacytoid cells, and some were showing prominent nucleoli. So since I reported this case, I had a gut feeling of could it be melanoma. So HMB45 also was done, and it was negative. So after these two turned negative with the CECT findings and the microscopic appearance,
we got a CD138. If you can see here, it is, I mean, there's no area that has not taken up the stain. So we are seeing near total staining by CD138, and also kappa also showed positivity. So with the immunohistochemical findings, along with the clinical history, CECT findings, and the microscopic findings, we made a provisional diagnosis of plasmacytoma lung, and we did ask, probably arising from the second or third rib and then infiltrating the lung, and we asked them to investigate for other CRAB features. And the patient did not reveal any hypercalcemia. There was no plasmacytosis on the bone marrow, and renal functions were intact. And skeletal survey did not reveal any other lytic lesions, and immunofixation and serum and urine electrophoresis did not show any MBAN. So the final diagnosis was plasmacytoma of the lung. So as we all know, I'm not going to go into details because Dr. Aditya has asked us to wind up before 4:45, and we need to keep the other slides also for discussion. So plasmacytoma commonly arises in the axial skeleton, and extramedullary sites are nasal cavity and paranasal sinuses. And I am sure all of us know that before making a diagnosis of solitary plasmacytoma, there has to be an extensive investigation to rule out a part of this as multiple myeloma. And especially when plasmacytoma arises in the spine, it is an emergency because patient may progress by the time we give the report from paraparesis to paraplegia or quadriplegia, depending on the location of the plasmacytoma. So because once we diagnose this, they can give a bout of radiotherapy, which can relieve the tension on the spine and save the limbs. So it's a kind of solitary plasmacytoma, especially in the spine, is a kind of emergency. Plasmacytoma lung is not a very common finding, but among the common sites of solitary plasmacytoma, ribs are also mentioned. There is no separate, we could not find an isolated involvement or incidence of the rib involvement. Thank you, Madhurya, and I like your name, Madhurya, very beautiful name. Aditya, can we ask them to present the
Yes, yes. I request now Dr. Nathan to share a screen and present D5.
Yeah.
Ma'am, please stop sharing the screen.
Yes.
Nathan, over to you. Dr. Nathan is from KIMS Hubli. Nathan, just check your audio once and...
am I audible, sir?
Yes, you're audible. Share your screen.
Yes, sir.
Nathan, what is the issue?
I have shared screen, sir.
You have not shared your screen. So click on share screen.
Okay, sir.
Select entire screen and then open a PowerPoint, start testing. Thank you.
Is it visible, sir? Can I start?
Yes, it's visible, Nitin.
So, good afternoon to all. Case allotted to me is case number D5. History provided is 44-year-old female presented with intermittent colicky pain in the abdomen since 6 months. USG abdomen showed a hyperechoic mass with thickened bowel wall. Patient underwent exploratory laboratory. Slides for interpretation. So 3 slides are provided. So this is the first slide. It's a section showing small intestinal mucosal epithelium with ulceration, as you can see. Periphery of the slide is showing smooth muscle bundles, and also one area of calcification is also noted.
Dr. Nathan.
On higher magnification, that ulcerated area is replaced by granulation tissue, as you can see in this image. Also, muscularis propria showing tumor cells arranged in interlacing fascicles. It is also extending to muscularis mucosa, causing atrophy. Tumor cells are arranged in interlacing fascicles and also in bundles. This is a high power view of the tumor cells. So tumor cells, as you can see, are oval to spindle, having vesicular nucleus, fine chromatin, 1 to 2 conspicuous nuclei, and moderate amount of eosinophilic cytoplasm. Occasional mitotic figures are also seen. This is a stroma showing keloidal fibers. Another area of stroma showing keloidal fibers. Here, tumor cells are seen infiltrating the muscularis propria. Other slide also shows the same findings of the tumor with the ulceration of the epithelium. Also, stroma shows variable amount of hyalinization. Tumor cells also showed thin-walled capillaries with perivascular lymphoplasmacytic infiltrates. So, also microvascular hemorrhage with extravasation of RBCs are also noted. So, the microscope is multiple section study shows small intestine with focal area showing mucosal ulceration and granulation tissue. Tumor cells appears to arise from the muscularis propria with atrophy of muscularis mucosa and lamina propria. Tumor cells are arranged in interlacing bundles and fascicles. These cells are oval to spindle having vesicular nucleus, fine chromatin, 1 to 2 conspicuous nuclei, and moderate amount of eosinophilic cytoplasm. Occasional mitotic figures are also seen. Intervening stroma shows keloidal fibers and zones of hyalinization. These cells are seen infiltrating into the muscularis propria. Periphery shows entrapped and atrophic smooth muscle bundles. Thin-walled capillaries shows perivascular lymphoplasmacytic infiltrates. So my diagnosis is feature suggestive of intra-abdominal desmoid fibromatosis. These are my possible differential diagnosis to be considered. One, we can consider nerve sheath tumor, including neurofibroma, schwannoma, then GIST and inflammatory myofibroblastic tumor. So if we compare desmoid fibromatosis with the nerve sheath tumor, the cell type are slender or spindle in desmoid fibromatosis, where it is in spindle shape with elongated wavy in nerve sheath tumor. Nucleus will be tapering, bland and small nuclei, whether in nerve sheath tumor it is wavy, serpentine, or palisading as in schwannoma. Then architecture, if you are seeing it is sweeping vesicles and it is infiltrated in desmoid fibromatosis, whether it is in nerve sheath tumor, we can have Antony A or B area in schwannoma and disorganized in neurofibroma. Stroma, we can see mesoid or keloid like hyalinized in stroma in desmoid fibromatosis, whereas in nerve sheath tumor there will be Uricay bodies, mesoid in schwannoma and collagenous in neurofibroma. If we're talking about atypia, low mitotic rate is seen, and there is no atypia. Similar also in nerve sheath tumor, we have low mitotic rate. Then other features are dilated vessels, edema, and hemorrhage in desmoid fibromatosis. Whereas in nerve sheath tumor, there will be thick vessels as in schwannoma and embedded axon in neurofibroma. Encapsulation, if you are telling it is ill-defined and it is locally infiltrated in desmoid fibromatosis, whereas it is in nerve sheath tumor, it is well encapsulated and poorly circumscribed. And IHC SMA is positive in desmoid fibromatosis. More common beta catenin is 80% positive in desmoid fibromatosis, whether it is negative in nerve sheath tumor. If you are comparing GIST and inflammatory myofibroblastic tumor with desmoid fibromatosis, GIST we have spindle or epithelioid, whereas in inflammatory myofibroblastic tumor there will be plump spindle cells or ganglion. Also we have epithelioid variant. Desmoid, it will be cell type will be slender spindle or cellate cell. Also cytoplasm will be pale to eosinophilic in fibrillary in GIST, where it is we have desmoid in desmoid fibromatosis, it is scan cytoplasm. And architecture GIST we have sheet storiform palisading and ski-node fibers, whereas in inflammatory myofibromatosis it is loose combat fascicles and also inflammation. So in desmoid fibromatosis, it is long sweeping vesicles. Stroma is hyalinized in GIST and desmoid fibromatosis. It is a myxoid or collagenous and also lymphoplasmacytic in inflammatory myofibroblastic. Mitotic activity in GIST it can be either high or it can be low. In inflammatory and desmoid, mitotic activity is usually low. And necrosis in GIST it is possible in treated tumors, whereas in inflammatory it is rare and desmoid fibromatosis is absent. If you are telling the special features, this still has keynote fibers. It's just diffusion and dedifferentiation. Whereas in inflammatory, there will be mixed trauma and neutrophils, and desmotic, there will be inflammatory growth, edema, and hemorrhage. And IHCA, same. It is positive for beta. Desmond fibromat is positive for beta catenin. Gist is positive for KIT and dog one. Thank you.
Thank you, Nitin. I
Thank you.
think my job has become extremely easy.
Minimize. Minimize. Open up PPT. PPT open up, close it. Scroll down. Share. Share. Slide.
Yeah, most of it Nitin has done. My job has become very easy, and we can stick to time because I'll take hardly a minute or so to discuss this case, because he has extensively discussed the differential diagnosis, the IHC, and the possible features, microscopic features. My only concern is that, especially for a postgraduate, when seeing a spindle cell lesion in the intestine, because your final diagnosis was intra-abdominal fibromatosis, and then you had the differential diagnosis of GIST, leiomyoma, etc. I would have wished that you had put the more common ones as your provisional diagnosis, because as a postgraduate, I would still want somebody to look at the common things first, because the incidence of intra-abdominal fibromatosis, that too in a jejunum, is very, very rare. So I would, I mean, since you had made a final diagnosis of intra-abdominal fibromatosis, I have a little problem with that, because I wish that you PGs always think of the common conditions first rather than thinking of the rare conditions. That would be my take-home message for this slide. And if you look at the radiological details, patient had presented with black-colored stools in 15 days and had a well-defined hypoechoic lesion in the left lumbar region according to the ultrasound, whereas the CT showed a well-defined intraluminal lesion in the distal jejunal segment. Basically, their diagnosis also was GIST bar leiomyoma on radiological findings. If you look at the gross, we received a really nice tennis ball like almost very well circumscribed very well circumscribed okay, I'm sorry for the disruption. So if you look at this here, we almost received a tennis ball like nodule covered by mucosa and almost very circumscribed. And if you look at this, it was almost jetting like a polypoidal kind of mass. And if you look at the cut section, you can see a very well circumscribed lesion, almost limited by the serosa, and has a nice French cap of mucosa with focal ulceration. And if you look at the corresponding microscopy here, as Nitin has showed, there is a focal ulceration here. And in the submucosal plane, almost abutting or pushing, this is this well circumscribed mass, relatively looking very bland and pale actually on low power. And Nitin has detailedly showed the features of this tumor, very spindly. At places it is having pointed edges, at places it is looking ovoid edges, with a very fragile kind of wispy cytoplasm, and there are some blood vessels interspersed here and there. Generally a very low proliferative lesion. If you look, there is not much of active mitosis If you look at this picture, at places it is having this wavy collagen in between, right? And similar picture on another. And if you look at the hyper, you are having this keloidal kind of collagen fibers, which are spared or stripped apart with little amount of edema. And there are these ovoid, almost myofibroblast-like cells with vesicular chromatin and prominent nucleoli and coarsely clumped chromatin, but here also you can see that it is mitotically less active. Same here. Inflammatory cells were very sparse. You can see there is hardly any. You can identify one cell here. Otherwise, we are not, throughout the section, the multiple sections, we could not find any inflammatory cells. The responses received, most common response received was the gastrointestinal stromal tumor, which I also completely agree, because that should have been the right response. Excuse me. The others were schwannoma, GAND. MPNST was one diagnosis, leiomyoma, solitary fibrous tumor, and desmoid or intra-abdominal fibromatosis. So now here we are. The IHC has played spoil sport, though we said it's GIST on radiology, GIST on microscopy probable, but as expected, we got the DOG1 and CD117, which are the common markers, which were negative. STAT6 for solitary fibrous tumor was also negative. S100 ruled out negative, ruled out schwannoma. SMA showed focal here and there positivity, but still we were not very, probably about 10% of the cells here and there showed SMA positivity. Then we have the hero of this case, or the heroine of this case. We have beta-catenin. Almost about 80% of the tumor cells showed nuclear positivity for beta-catenin, and high power of the same showing nuclear positivity, and hence the final diagnosis was intra-abdominal fibromatosis. At this juncture, I would like to thank Dr. Rekha from Shankara Institute, who, when we sent for a second opinion, also helped us in arriving at the diagnosis. So I would like to acknowledge Madam's help in this case. So as we all know, intra-abdominal fibromatosis is not very common. Among the desmoid fibromatosis, I'm sorry for the spelling mistake here. So 85% of them are sporadic with different gene, and if you see here, about 15% are familial association with APC gene. So whenever we find desmoid kind of fibromatosis, whether it is extra-abdominal or intra-abdominal, probably screening for APC should be the case, especially if there is a family history, because that will give rise to a lot of other findings which may be relevant for the patient. It is very less common, as I said, about 15% of desmoid fibromatosis. And as all, even the desmoid fibromatosis, intra-abdominal fibromatosis is also associated with previous trauma, abdominal surgery, pregnancy. It's commonly seen like, in other desmoid fibromatosis, commonly seen in females. It is locally infiltrative, obviously non-metastatic, can present with intestinal bleeding and obstruction. Unfortunately, like all fibromatosis, it has got a recurrence rate of 50%. But in our case, patient is on follow-up and until now has been doing well and did not have any familial association with this kind. And patient is been doing well till now. Thank you. Case answers. And at this juncture, I would want to thank KCIAPM and for giving us this opportunity to host this slide seminar. I hope the slides were interesting and made a good learning for the postgraduates. We did definitely enjoy the process of preparing for this slide seminar and sharing the little bit knowledge and the interesting cases. These cases were selected because most of the times, whenever we have slide seminars, predominantly we are thinking of malignancies, and most of our cases were borderline cases, which PGs also should keep in mind when making a diagnosis. And again, I would reiterate that whenever uncommon things are always uncommon, common things should be kept in mind, and morphology is the king, and with morphology IHC can be a helpful feature. And I thank Dr. Aditya for guiding us through this session and giving KIMS an opportunity to host the slide seminar.
Okay, the answers for the last two questions. One was, I'll just share the screen. This is actually a case of spiroketosis. One of them I've got this correctly. This brush border over here, spiroketosis, a treponemial infection. If you can notice, this is actually very common, which is ignored most often. And the other one, this I think is a easy pickings. This is dermatophytosis, florid dermatophytosis, wherein you have hyphae here. It was a scalp biopsy, and we gave it a Stenia capitis. There's one more question. Maybe we can discuss it after the chat box. This is a very interesting thing. You can just have a look and share your answers. And thank you for this opportunity.
Thank you, sir.
Thank you, Aditya.
Thank you. So that brings us to the end of the set by KIMS Bengaluru. The answers are already coming in the chat box, sir.
Yeah. I'll post the answer for the last one in the chat box later. Okay.
Thank you. Thank you, Nivedam. Thank you, Tejvi sir, and all the faculty from KIMS Bengaluru for such wonderful cases. With that, we'll move to the next set by Vedic Institute of Medical Sciences, Bengaluru. And to begin that, I first invite Dr. Tissa to present S1. Dr. Tissa is from Kanachur Institute of Medical Sciences. I request Dr. Tissa to unmute herself and share your screen. Meanwhile, Dr. Devasmita, are you ready there? Dr. Devasmita? Yes, Dr. Tissa, please share your screen.
Yes.
Dr. Devasmita, our faculty from Vedic, request you to unmute yourself once. Just hold on, Tessa.
Hello. Sir, am I audible?
You're audible. Just hold on for a moment. We'll
Okay,
have
sir. Okay, sure, sir.
also on board. Dr. Devasmita, you're there?
Yes, I'm here.
Dr. Tissa, you can go ahead and share your screen and begin with S4.
Okay, sure, sir. So, good afternoon, everyone. Myself, Dr. Tissa Robinson, second year postgraduate from Kanachur Institute of Medical Science. So today I'm going to discuss about the case number 1. We have given from clinical history which was provided was a 49-year-old female patient presented with sinonasal mass, and they have also given a query fibrous dysplasia and excision biopsy for interpretation. So moving on to the microscopy, this is a scanner view where you can see multiple tissue bits, and in low power view, here the focal area of tissue is lined by stratified squamous epithelium, and in some areas we can see bone and cartilage and some green, and again in multiple areas it shows many of the fungal elements. Here in this slide, the background shows mixed inflammatory infiltrates, which is predominantly composed of eosinophils with few plasma cells, lymphocytes, and occasional neutrophils. So again in this slide, many histiocytes are seen. Moving on to the next slide, where in high power view, there is a histiocytes which aggregates together and forming the giant cells. So my summary is, where the section studies shows the tissues bits which are focally lined by stratified squamous epithelium, and the fungal elements which is seen having broad acetate and showing wide angle branching, and adjacent tissue fragments which shows mixed inflammatory infiltrate, which is comprising of predominantly of eosinophils, lymphocyte, plasma cell, and occasional neutrophils. So my differential diagnosis, which includes mucormycosis, and second one aspergillosis. Mucormycosis is my diagnosis, as it shows the wide angle branching, and also it is showing the broad acetate fungal hyphae, and also the it shows it angle is showing its right angle. And why not aspergillosis? Because it is thin and having septate, and it is having the acute angle. So my diagnosis is mucormycosis. So to confirm, we can do the special stains for fungus, which includes the GMS and PAS stain, where the GMS is the Grobot Chromori methenamine silver stain, where the fungal elements will be showing black color or gray, and in PAS, the fungus will be branches of the fungus will be showing in magenta color. So thank you everyone.
Thank you. Now we'll be sharing our screen from Vaidehi.
Dr. Devsula, please start the video as well.
Yes, sir. Starting, sir. 2 minutes.
I think you've shared your entire screen.
Okay,
Please
sir.
stop sharing. Share entire screen.
Entire screen, sir.
Start a video and share entire screen. Yes. Go ahead.
Good presentation, Dr. Tisa. She has rightly described all the features. So I will be taking through the slides now. I'm Dr. Divya, Associate Professor from VIMS in RC Bangalore. So this was a history provided to us. A patient was a 49-year-old female with right sinonasal mass and nasal obstruction since 2 months. She had history of nasal discharge. There was no history of facial pain or headache or blurring of vision. There was no history of loss of appetite and weight loss. And she was a known case of bronchial asthma. And there was no history of diabetes mellitus or any risk factors for fungal infections like hematological malignancies, or the patient was on any chemo or immunotherapy. So on examination, there was a globular swelling at the dorsum of the nose extending into the right nasolabial fold. It was non-mobile, non-tender and hard in consistency, and skin over the swelling appeared normal. CECT PNS was done, and there was a soft tissue thickening in the right maxillary sinus extending through the right osteomeatal complex, filling the right side of the nasal cavity, involving the ethmoidal and frontal sinus, suggestive of extending up to the choana, suggestive of antrochoanal polyp. The clinicians had also suspected fibrous dysplasia. So after which endoscopic excision of the right nasal mass was done. Intraoperatively, there was a proliferative growth noted occupying the whole right nasal cavity, involving the complete lateral wall extending up to the posterior ethmoidal sinus. So, and then we had received the excision biopsy. So there were multiple tissue bits. So as Dr. Tisa had already explained, I will quickly go through the slides. So the tissue was partly lined by stratified squamous epithelium, and at lower magnification, I just want you to look at these eosinophilic amorphous material at low power. So at higher magnification, we could see there was a dense inflammation richly composed of eosinophils, lymphocytes, plasma cells, histiocytes, and few neutrophils. And we could see fungal hyphae highlighted, and this was encased by this eosinophilic material, amorphous eosinophilic material. So actually, the fungal hyphae are getting highlighted by this eosinophilic material. So we could see some granulomas as well with giant cells, epithelioid cells, and then we went ahead with special stains, that is PAS and GMS, highlighting the fungal hyphae. So these fungal hyphae, so the fungal hyphae, they resemble mucormycosis, like broad aseptate, thin-walled, widely spaced septate to posiseptate hyphae. And the eosinophilic material surrounding the fungal hyphae was also highlighted by the PAS stain, so which was Splendor-Hopley phenomena. So to summarize, there were eosinophilic granulomas, and this eosinophilic material highlighting the encasing the fungal hyphae, Splendor-Hopley phenomena, the fungal hyphae were posiseptate with irregular branching, and there was no evidence of necrosis or angioinvasion or any tissue invasion. So at this point, it is definitely fungal sinusitis. So after extensive research and thorough review of literature, we came across this entity called entomophthalomycosis, which is a subcutaneous and a mucocutaneous infection. So we had referred all these articles. And the final impression of entomophthalomycosis, conidiobolomycosis, was given. So these are the responses received. That is mucormycosis, aspergillosis, allergic fungal sinusitis, granulomatous inflammation, secondary to parasitic or fungal infection, pheohyphomycosis, inflammatory myofibroblastic tumor, sinonasal undifferentiated carcinoma, fibrous dysplasia with aneurysmal bone cyst. So I will just take you through each differential. So coming to mucormycosis, it was already described by Dr. Anita KIMS staff. So you usually see broad aseptate hyphae with irregular branching, and also you see angioinvasion with tissue necrosis. Same with aspergillosis, where you see angioinvasion and necrosis. So the septate hyphae with acute angle branching is seen, and these two entities are usually seen in immunocompromised individuals. But in our case, the patient was an immunocompetent host. So we could rule out mucormycosis and aspergillosis. So the other differential was pheohyphomycosis. So we could usually in pheohyphomycosis you see darkly pigmented fungal hyphae along with Splendor-Hopley phenomena. So there was no presence of Splendor-Hopley phenomena. Darkly pigmented hyphae in our case. Coming to IMT, although there is rich inflammatory cell infiltrate, distinct presence of fungal hyphae will rule out inflammatory myofibroblastic tumor. So we also thought about allergic fungal sinusitis because the patient was a known case of bronchial asthma and she also had peripheral eosinophilia. So, but in allergic fungal sinusitis, you usually see eosinophilic mucin. So, eosinophilic mucin with sloughed epithelial cells, eosinophils, and Charcot-Leyden crystals with fungal hyphae. So, this was also ruled out. So there were other differentials like fibrous dysplasia. We could not find any Chinese letter pattern or any also aneurysmal bone cyst features. So there was no hemorrhage or anything. So that was ruled out. And also sinonasal undifferentiated carcinoma, there were no neoplastic cells in our case. So coming to the discussion, so entomophthalomycosis, so it is a group of rare subcutaneous and mucocutaneous fungal infection. So these are identified as parasites infecting insects, so hence the name entomon in Greek meaning insect. So entomophthalomycosis, it comes under a broader category called subcutaneous zygomycosis, and this also includes mucormycosis, mucorales. So entomophthalomycosis again has two main types, that is basidiobolomycosis and conidiobolomycosis. So usually basidiobolomycosis is caused by Basidiobolus renarum and conidiobolomycosis is caused by Conidiobolus coronatus most commonly. So it occurs usually in tropical and subtropical regions and usually affects the immunocompetent individuals like in our case. So you usually see basidiobolomycosis in children and young adults and conidiobolomycosis in adult males. And these are harbored in soil, insect, reptile and amphibian excreta. So the mode of transmission in case of basidiobolus is through minor trauma or insect bites, whereas conidiobolus is through inhalation of the spores or minor trauma. Usually we don't see any person-to-person transmission. Coming to the clinical features of basidiobolomycosis, so usually men are affected more than women and you usually see erythematous nodular lesions on the trunk, limbs, buttocks and muscles, bones and regional lymph nodes. It can also affect gastrointestinal system which mimics inflammatory bowel disease and malignancy. Whereas conidiobolomycosis, it usually affects the mucocutaneous facial structures like in our case. Hence, we had diagnosed it as conidiobolomycosis under entomophthalomycosis. So it usually progresses slowly with edema causing disfigurement of the face and sequelae. It may also cause intracranial spread resulting in rhino-orbitocerebral infection. So as we had already discussed, these are the histopathological features. It has characteristic histopathological features like eosinophilic granulomas, Splendor-Hopley phenomena. So the hyphae are usually highlighted because of the encasing Splendor-Hopley phenomena. And they are composed of eosinophils, lymphocytes, plasma cells, and epithelioid cells. And there will be fibrosis as well. So, and the fungal hyphae are broad, thin-walled and sparsely septate, irregular branching, and distinctly there is no angio-invasion, necrosis or tissue invasion. So what is Splendor-Hopley phenomena? This is eosinophilic amorphous material surrounding the fungal hyphae seen as radiating starburst structures. It indicates immune complex deposition. So you can diagnose fungal by special stains like PAS and GMS. Mycological cultures can be used. Molecular identification can be done by DNA probes and real-time PCR, and the extent of the disease can be determined by MRI and CT. So the key difference is, it is important that we differentiate between the entomophthalomycosis and mucormycosis. So entomophthalomycosis usually seen in immunocompetent host, and you usually don't see angio-invasion in Splendor-Hopley, and mucormycosis usually seen in immunocompromised host with angio-invasion and presence of necrosis. So the treatment and follow-up, usually antifungals are given and surgical debulking. The prognosis is generally good with early treatment, and delayed treatment can lead to spread and disfigurement. So entomophthalomycosis is a rare fungal infection but with presence of characteristic histological features. So histopathology is diagnostic and it can be diagnosed based on the morphological features. So early recognition is crucial to avoid any complications, intracranial spread and disfigurement of the face. These are my references. So this entity was mentioned even in IADVL textbook of dermatopathology. Thank you.
Thank you. I think with that, we'll move to the next one. That is S2 by Dr. Nayana from Saptagiri.
Yes, sir.
Please keep the presentation brief and to the time.
Sir, am I audible?
Please go ahead.
Is my screen visible, sir?
Yes.
Sir, I'm Dr. Nayana, third year postgraduate from Medical Sciences and Research Center, Bangalore. The case allotted to me is quarter number 2 with a history of a year-old male presented with right parotid region mass. This was the microscopic images. In scanner view, we can see normal parotid parenchyma along with an invasive malignant tumor. In low power view, we can see tumor cells in nests and sheets and occasional mucinous cells along with clusters of intermediate cells can be seen. In this, we can see epidermoid cells in sheets and nests. Here, clusters of mucinous cells can be seen along with epidermoid tumor cells in sheets and nests having high NC ratio, hyperchromatic nuclei, irregular nuclear borders, prominent nucleoli with moderate amount of eosinophilic cytoplasm can be seen. Perineural invasion and lymphovascular invasion was noted. Here we can see the tumor cells infiltrating into the surrounding stroma. And on high power, few mitotic figures were also noted. And the stroma had shown fibrocollagenous tissue. So summary is, the section studied show an invasive malignant tumor comprising predominantly epidermoid component along with varying proportion of intermediate cells and occasional mucinous cells. Epidermoid cells were seen majorly in solid sheets, solid nests, sheets and rods. Mitotic figures were also noted. Perineural invasion and lymphovascular invasion was also noted. Hence, the impression was given as high-grade mucoepidermoid carcinoma. Thank you.
Thank you. Back to Dr. Devismita.
Hello, am I audible?
Please go ahead.
Yes. Hello, everyone. Myself, Dr. Kavya. I'm Assistant Professor at Department of Pathology, VIMS and ASI. So, Dr. Naina, you covered most of the points well presented. So, let's see in detail about this case. So this was a 55-year-old male patient who was former by occupation, presented with a hard swelling over right cheek since 4 months, and it was rapidly progressive in size and was associated with pain. And he was a chronic smoker and beaten at church for more than 15 years. So there was no history of similar complaints in the past or no history of previous surgeries, and there was no history of difficulty in swallowing the food or fever or weight loss. So CT head and neck was performed and it showed ill-defined lobulated heterogeneous lesion in the right parotid gland involving the superficial lobe with extension into the deep lobe with areas of calcification and necrosis. And also there were few enlarged cervical group of lymph nodes. So here you can see heterogeneous ill-defined mass with areas of necrosis and microcalcifications. Further, the FNEC was performed from the swelling, which was firm to hard on palpation. It was around 3 to 2 centimeters, fixed and non-tender. So this was the cytological image. Here you can see sheets of the tumor cells. It was moderately cellular, and you can see the loose cohesive clusters of the cells with prominent nucleoli, granular chromatin. The same picture depicted here. You can see the prominent nucleoli, granular chromatin, high NC ratio. So on cytology, it was positive for malignancy, and we considered the possibility of high-grade carcinoma, and the possible differential diagnosis which we considered were salivary duct carcinoma and adenocarcinoma. So we categorized it under Milan category 6. So further, we received the complete excision specimen of right parotid gland, which was around 5 into 3.5 into 3 centimeters. On serial sectioning, we found a well-defined firm gray white to gray yellow lesion, which had completely replaced the normal parenchyma, and it measured around 3 into 3.0 into 2.5 centimeter, and the overlying skin ellipse was inward. And also we received level 2 lymph nodes. So coming to the microscopic pictures, so here we could see the tumor infiltration, which are predominantly arranged in cords and nests. Here you can see the cords and nests arrangement of the tumor cells. The same picture. And on IPAR view, we can see these cells in a infiltrating pattern, which is somewhat similar to that of the IDC breast, that is invasive ductal carcinoma breast. These cells have high NC ratio, they are highly pleomorphic with prominent nucleoli, and a good number of eosinophilic cytoplasm. And also we saw 4 to 5 atypical mitosis per IPAR field. So also we noted perineural invasion, and there was evidence of focal comedonecrosis. So this is the comedonecrosis. The tumor cells are around the surrounding the comedonecrosis. The same image is shown here. And also we isolated 34 lymph nodes, in which 9 lymph nodes show metastatic deposits of carcinoma with extranodal extension. So with this, our provisional diagnosis was high-grade carcinoma favoring salivary duct carcinoma versus other high-grade adenocarcinomas. So we went ahead and performed pan-CK, which showed strong and diffuse immunoreactivity, that is cytoplasmic positivity. You can see here. So, and also HER2 was performed, which showed complete membranous positivity. And also we performed one of the specific marker for salivary duct carcinoma. Here you can see the nuclear positivity, which was diffuse. And also GATA3 was performed, which showed nuclear positivity. So with all this workup, we finally concluded it as salivary duct carcinoma. And also ERPR was performed, which was negative, and also P63 was negative, which ruled out the possibilities of metastatic breast carcinoma and also mucoepidermoid carcinoma. So the responses which we received were, most of the answers were correct, that was salivary duct carcinoma, followed by high-grade mucoepidermoid carcinoma, followed by adenoid cystic carcinoma, intraductal carcinoma, adenosquamous carcinoma, carcinoma is pleomorphic adenoma, and metastatic urothelial carcinoma. So in brief, we will see how to differentiate these primary high-grade carcinomas of salivary gland. So first one is salivary duct carcinoma, followed by adenoid cystic carcinoma, high-grade mucoepidermoid carcinoma, and intraductal carcinoma. So as we saw in our case, these tumor cells were arranged in infiltrative growth pattern and also solid nests and duct-like pattern. So in solid variant of adenoid cystic carcinoma, usually the tumor cells will be basiloid in nature with uniform nuclei. So here, but in our salivary duct carcinoma, the cells were highly pleomorphic with conspicuous nucleoli. Whereas in high-grade mucoepidermoid carcinoma, we see all these three cell variant, that is epidermoid, mucus, and intermediate cells. And usually the architecture is generally more organized in case of high-grade mucoepidermoid carcinoma. Whereas the intraductal variant usually depicts the same morphology as of salivary duct carcinoma, but it is very much confined within the ducts. So, coming to the perineural invasion, it is more commonly associated with solid variant of adenoid cystic carcinoma and in some cases of salivary duct carcinoma. Necrosis is often focal comedonecrosis in case of salivary duct carcinoma. Usually in adenoid cystic carcinoma, the necrosis is rare and usually it is diffuse necrosis seen in high-grade mucoepidermoid carcinoma. So coming to the IHC profile, how to differentiate each entity. So usually the salivary duct carcinoma show positivity for androgen receptor, which is the apocrine variant, followed by GATA3, PAN-CK and HER2. So these are the more specific markers and AR is the most specific marker, which around 90 to 100% of the cells take up this stain. And usually it is negative for P63, ER and PR, which was similar to that of in our case. Adenoid cystic carcinoma usually consists of ductal component as well as the myoepithelial component. So it will be positive for both ductal and epithelial component, whereas it is negative for androgen receptor and GATA3. And 10 to 30% of the cases can show HER2 positivity. Coming to high-grade mucoepidermoid carcinoma, it is positive for pancytokeratin P40, P63. In our case, P63 was negative, and also the membrane-bound mucins will be positive for MUC1, MUC2, MUC4, and MUC5. So we have to remember that this high-grade mucoepidermoid carcinoma will be negative for S100, androgen receptor, and HER2. So intraductal carcinoma will show similar expression as that of salivary duct carcinoma. However, it is negative for androgen receptor expression and HER2 expression. Coming to the brief discussion, salivary duct carcinoma is an aggressive subtype of primary salivary gland carcinoma, often presents with an advanced stage and has high rates of metastasis and recurrence. It mostly arises in the parotid gland and is usually seen in the elderly male. Microscopically, it resembles the high-grade breast ductal carcinoma and thus the name. So the latest version of National Comprehensive Cancer Network guidelines recommends the evaluation of androgen receptor and HER2 in the suspected cases of salivary duct carcinoma before releasing the report. So we can see few histological variants of salivary duct carcinoma, which includes mucin-rich, sarcomatoid, invasive micropapillary, oncocytic, and rhabdoid variant. However, the sarcomatoid, invasive micropapillary, and rhabdoid variant are known to show the poor prognosis compared to the conventional salivary duct carcinoma. So the main differential diagnosis, that is invasive ductal carcinoma, that is the metastatic invasive ductal carcinoma, has to be ruled out based on the markers like ER, PR and HER2 and also to perform AR. Thank you.
With that, we'll invite Annette Verghese from SS Institute, Downview, to present S3. Dr. Annette, please unmute yourself and go ahead. Dr. Annette, request you to unmute. We lost Annette there. Dr. Annette, you're still around? I think some network issues there. Dr. Annette is, you're back. Okay, please unmute yourself.
Am I audible?
Yes, you are audible. Please put it on slideshow mode and start your presentation, and keep the presentation very brief.
Yes.
Slideshow mode, please.
So very good.
Yes.
Yes,
Go
sir.
ahead.
A very good afternoon to everyone. Myself, Dr. Annette Verghese, first year pathology postgraduate in SSIS. So the case allotted is S3, 36 female, contoured solid pelvic mass for evaluation. So in the scanner view, we could see a well delineated lesion, cellular and hypocellular and hypercellular areas. Shifting to low power, the cells were arranged in nodular pattern and trauma. Individual vessels cigar shape is eosinophilic cytoplasm. Can also see
Dr. Davis, I think her network is not that good. I don't think she'll be able to.
Yes, sir. Yes, sir.
I think her network on her side is not good.
Okay.
I doubt whether she'll be able to complete the presentation.
Okay, sir.
So, I think faculty can go ahead and discuss the case.
Fine, sir. I'll do that.
Just present. Yeah.
Good evening, everyone. I am Dr. Davis Mehta, and I really hope I'm audible. Unfortunately, Dr. Annette didn't finish her PPT, but we'll continue. So today we'll be starting talking about the spotted number 3. The history provided was a 36-year-old female who presented with an irregularly contoured solid pelvic mass for evaluation. The history which we already knew was the patient who had pain or abdominal discomfort in the lower abdomen since 3 years, which was gradual in onset and progressive in nature, but no other significant history was provided. Radiologically, on an MRI, we saw a solid mass which extended from the pelvis into the abdominal cavity around 25 to 20 centimeters, which was encasing the left ovary and also the fundal and posterior aspect of the uterus. There was no other significant lymphadenopathy. So on MRI, the DDs which were provided were uterine leiomyoma and peritoneal mesothelioma. So first we received a USG-guided small biopsy from the same specimen, which showed multiple nodules and there were spindle cells. So with this, we could just give a diagnosis of spindle cell neoplasm, and they further went and excised the mass. So when we see the mass, we got the specimen of uterocervix in one container with bilateral adnexa, and the posterior surface of the uterus was slightly raw and ulcerated. And on the other hand, we got another container which contained the main mass in multiple bits and pieces. What was most significant in that was the external surface of that mass. There were multiple nodules seen on this. And when you see this, what you can think of is the placenta, the cotyledons of the placenta. So then microscopically, we can see there are multiple nodules of tumor cells. And as we see from a higher power to a lower power, from a lower power to a higher power, we can see these nodules are predominantly in the fascicles and whorls. And they contain predominantly these kind of spindle cells, which are bland. So these benign appearing cells show bland, plump spindle nuclei with eosinophilic cytoplasm. The mitotic index was low. When we look at these nuclei, what does it appear like? It kind of looks like a cigar shape. So these were cigar-shaped nuclei. The myometrium, there was dissection into the myometrium, and there was focal stromal edema and hydropic degeneration. So overall, I wish Dr. Annette could present this. There were nodules of tumor cell proliferation separated by loose fibrous tissue. Individual cells were splintly. They were elongated to oval, like I said, cigar shape. There was no nuclear atypia, no bizarre cells, no necrosis, and mitotic was comparatively sparse. On the other hand, the uterocervix and the bilateral adnexa was almost normal, except the posterior surface of the myometrium, which showed the tumor cells. So now what do we ask ourselves? Is this a benign lesion? Is it a malignant lesion? Is it a spindle lesion? If spindle, is it smooth muscle? Is it neural, or is it something else altogether? To confirm that, we did IHC. So IHC showed SMA positivity, smooth muscle actin positivity, Caldesmon positivity. Both of these together gave us an idea, okay, it could be smooth muscle origin. Ki67 proliferative index was low and S100 was negative. So this is the IHC interpretation of the same. And we came to a final impression of
cotyledonoid dissecting leiomyoma. Why cotyledonoid? Because externally the outer surface looked like cotyledons of the placenta. Dissecting, why? Because it dissects into the myometrium. Leiomyoma, because it looks like a benign spindle cell tumor. The responses which we received predominantly were leiomyoma and its variants. Then we also had a few which were showing a nerve cell neural origin. There were a few with ovarian and few fibrohistiocytic. We are okay with the ones with leiomyoma and its variants, but yeah, let's look into the different types. So diffuse leiomyomatosis, how do you differentiate? There are numerous confluent nodules with poorly defined borders. How do you differentiate disseminated peritoneal leiomyomatosis? Here, there will be, it's more in the peritoneal location, there are nodules, and the external surface won't show that placenta-like appearance. On the other hand, there were responses which said leiomyoma with bizarre nuclei or leiomyosarcoma, but in this, we did not really see any kind of bizarre nuclei or atypia or these kind of mitosis, so those were ruled out as well. Now coming to neural tumors, the nuclei were neither wavy nor were they pointy, so not really neural either. And neurothecoma, on the other hand, has both it has both spindle as well as epithelial appearance, so that also was out. So now, why do we need to know this? This is a very uncommon entity. It's a rare entity.
Dr. Davis, are you there?
There are numerous articles on the same. I would really like if you guys can read it up. These are my references. Thank you so much.
Thank you, Dr. Davis. I think with that, we'll move to the discussion cases. I request Dr. Saujanya from Al-Amin Medical College to present D4. D2.
Sir, am I audible?
Yes.
Yes. My PPT is visible, sir.
No, not yet.
Now, sir? One second.
Click on share screen and present entire screen.
Okay, sir. Now, sir?
No. Click on share screen, select entire screen, tap on the screen, and then click on share button.
So visible, sir?
Yes. Put it on slideshow mode and go ahead.
Shall I start, sir?
Yes, you have 4 minutes.
Yeah, my slide number is D2, sir. I am Dr. Saujanya CH from Al-Amin Medical College, Vijaypur. The case given to me was 51-year-old male patient evaluated for a presacral retroperitoneal mass, excision biopsy for interpretation, sir. This is the scanner view of the tissue. This is a 10x view, sir. This is what is my summary histological features. Or section study shows highly cellular tumor, predominantly composed of spindle to oval cells, arranged in intersecting fascicles and somewhat storiform pattern. So tumor cells have elongated nuclei showing moderate nuclear pleomorphism with fine chromatin and indistinct cytoplasmic borders. Nucleoli are visible in some cells. Background stroma is lightly eosinophilic, and my differential diagnosis are solitary fibrous tumor, synovial monophasic, leiomyosarcoma, which is hemangiopericytoma-like pattern, and undifferentiated pleomorphic sarcoma. Thank you, sir.
Go back to your place. Go back to your place. Go back, everybody. Go back. Go back to your place.
That was a easy presentation. Dr. Davis, back to you. Back to the Vaidehi team. Request to please unmute Dr. Davis before you start. Dr. Smita, I request you to unmute before you continue with the next case.
Good evening, everyone. I'm Dr. Sandhya, Assistant Professor, VIMS and RC Bengaluru. I'll be discussing about case 2. So this is 51-year-old male who presented with history of fever since 2 months, urinary retention and pain abdomen since 1.5
Just a
months.
second, please stop. I think you're not sharing the entire screen. Please share the entire screen, Dr. Devasmita.
Yes.
Stop sharing and reshare the entire screen.
Okay.
Put it on slideshow mode. Yes, please
He
go.
is a known alcoholic for say 5 to 6 years, chronic smoker. There was no significant past or family history. On examination, abdomen was soft, non-distended, but there was mild supraclavic tenderness. There was no mass or organomegaly. Per rectal examination showed grade 1 prostatomegaly, and a 4 into 5 centimeter external mass was felt at posterior region, but upper limit of which was not felt. However, rectal mucosa was free. On MRI, there was 10 into 10 centimeters space occupying lesion in the rectovesical space and presacral space, which was causing anterior displacement of urinary bladder and rectum. So based on all these features, TDs given were mesenchymal space occupying lesion, exophytic cyst or neurogenic tumor. So we have received a small biopsy. These showed a needle course of tissue with sheets of cells which were ovoid to spindle cells with indistinct cytoplasmic borders with collagen in the stroma. So impression given was spindle cell neoplasm and IHC was advised, which I'll discuss later. So based on IHC findings, they went ahead and did anterior resection with mass excision. This is the rectum and this is a mass adherent to this. On cut surface, we can see well circumscribed lobulated heterogeneous mass which is giving tan color, and we can see some areas of hemorrhage. So on microscopy, it is a well circumscribed tumor with a haphazardly arranged cells and vaguely storiform pattern can be seen. And we can also see many dilated branching thin-walled blood vessels. Individual cells are ovoid to spindle with mild nuclear atypia with indistinct cytoplasmic borders, and mitosis we can see there is increased mitosis. Also stromal collagen is also noted. So these are the responses we got: solitary fibrous tumor, monophasic synovial sarcoma, MPNST, GIST, low-grade fibrosarcoma, retroperitoneal sarcoma, and leiomyosarcoma. So IHC was done. PAN-CK was negative, so possibility of carcinoma is ruled out. Desmin was negative, so it is not a tumor of muscle origin. Vimentin is positive, it is a stromal tumor. S100 was negative, so MPNST is ruled out. CD34 showed diffuse membranous positivity. K67 was around 40%. CD117 was negative, so GIST is ruled out. TLE1 was negative, so synovial sarcoma is ruled out. STAT6 showed diffuse bright nuclear positivity. So based on these IHC findings, final diagnosis given was solitary fibrous tumor. So risk stratification was done to assess the possibility of metastasis. So for this patient, the risk category was intermediate risk. So I'll not be discussing all this theory due to time constraints. So in a middle-aged to elderly patient, we present with pain abdomen, urinary retention and constipation, who has well circumscribed lesions which were adherent to bowels, microscopy showing spindle cell lesions with variable collagenous stroma, admixed with branching and hyalinized staghorn-shaped blood vessels. Always solitary fibrous tumor should be considered as DD, even in abdominal cavity and retroperitoneal regions, and risk stratification has to be done. Thank you.
Thank you, Dr. Saujanya. Okay, I now request Dr. Saujanya to share the screen and present.
Yes, sir.
Saujanya is from Ramaya Medical College. She will now be presenting D3. Minimize the screen and open your PowerPoint.
Yes. Is it visible, sir?
Yeah, put it on slide show me.
Good afternoon, one and all. This is Dr. Saujanya HS, second year pathology resident from Ramaya Medical College. The clinical history provided was a 48-year-old female patient presented with left breast lump. She underwent mastectomy and slide for interpretation. So this shows a H&E section studied under scanner view, shows a infiltrating malignant neoplasm, which is also invading the adipose tissue. On further magnification, we can see that the tumor cells are arranged in diffuse sheets, and some are arranged in vague follicular pattern. So on further magnification, we can see that predominantly small to medium-sized neoplastic cells are seen with round to oval nucleus. This shows a H&E section under 40x magnification, shows few large cells. Few large cells are seen exhibiting high NC ratio and moderate degree of nuclear pleomorphism and vesicular chromatin, prominent nucleoli, and scant eosinophilic cytoplasm. Also, we can see a few mitotic figures are seen. So the black arrows are pointing towards mitotic figures. So microscopy section studied shows H&E stained microphotograph of breast parenchyma showing infiltrating malignant neoplasm, which is invading the stroma. The individual tumor cells are arranged in diffuse sheets and vague follicular pattern. The tumor cells are predominantly small to medium sized with round to oval shaped nucleus, and few large cells are seen exhibiting moderate degree of nuclear pleomorphism, prominent nucleoli, vesicular chromatin, and scant cytoplasm. Increased mitotic activity seen 2 to 4 per high power field. So my differential diagnosis is non-Hodgkin's lymphoma, and secondly, invasive lobular carcinoma, solid variant. So to further summarize, in our case, it was a well circumscribed lump in the breast, whereas in case of invasive lobular carcinoma, it is a poorly defined tumor is seen. Whereas in case of NHL or non-Hodgkin's lymphoma, the tumor will be well circumscribed. Coming to the microscopy of our case, the tumor cells were arranged in diffuse sheets and vague follicular pattern, and small to large sized atypical cells were seen, and increased mitotic activity is seen. Whereas in case of invasive lobular carcinoma, the tumor cells will be arranged predominantly in a single file or in a linear pattern, and also in diffuse sheets. Whereas in case of non-Hodgkin's lymphoma, the tumor cells, we see a diffuse proliferation of small to large-sized neoplastic cells. Therefore, the final impression is histological features are in favor of non-Hodgkin's lymphoma in view of the above findings and clinical history provided. Advised cytokeratin, CD45, PAX5, BCL2, BCL6, CD10, CD19, CD20, Chi67 ISC markers for further subtyping. Thank you.
Good evening. As Saujanya has already described, I will not get into the details of the morphology. She has rightly described the slides. So I'm Dr. Shilpa, Professor, Department of Pathology, VIMS and RC. This particular case, actually, it was not an in-house case. We did receive the case for review with 30 strain slides and 30 paraffin blocks. The patient was operated elsewhere outside for a left-sided mastectomy with axillary lymph node dissection. Mastectomy specimen measured around 20 by 16 into 88.5 with a gray-white fleshy tumor measuring 19 by 5.5 into 8 centimeter, which was involving the entire breast parenchyma. The skin and nipple areola complex appeared to be involved as per what was written in the report. So as we see, she has described the tumor cells were arranged in a diffuse pattern infiltrating the surrounding adipose tissue. So we were sure that it is some malignant neoplasm, but however, the diffuse arrangement was something which was bothering us at that point of time. So as we went to the higher power, we could see that they are definitely dispersed singly. The size of the cells were medium to large, and there was diffuse pattern of arrangement. So it really mind boggled us why the breast tumor is being seen like this. So when we went under higher power, the cells were round to oval with irregular nuclear contours with crumpled chromatin at places and scant cytoplasm. Few of the cells also showed nucleoli. And as we could see in few of the slides, there was a benign breast tissue which was still which was entrapped by the tumor, and the diffuse morphology of the tumor cells can also be seen. So coming to the final diagnosis was a little difficult for us, because something like this we had not seen in the breast. We started thinking whether it is a primary breast tumor or is it something which we commonly see and we are seeing it in a other place. So with all these features in our mind, we thought that it is a tumor, malignant tumor. Yes, it is not a usual tumor. If it is primary, then we thought of an invasive lobular carcinoma. We did consider a possibility of lymphoma, which is non-Hodgkin lymphoma. However, we also thought that it could still be a mesenchymal tumor in the breast. Keeping a high-grade malignancy in our mind, we discussed with our medical oncologist to go ahead with the IHC for this case. So we started with the lineage markers, that is pan-cytokeratin and CD45. As we can see, pan-CK was definitely negative in the tumor cells. However, the entrapped breast tissue which were remnant were showing positivity, and CD45 was diffusely positive in the tumor cells, telling us that yes, you are looking at the lymphoid lineage tumor. After that, once the CD45 was positive, it was little easy for us. So we started putting the T cell and B cell specific markers. So CD20 was diffusely positive, PAX5 was positive, showing a B cell lineage. CD3 was negative in the tumor cells. However, the background reactive T cells were positive. As we can see, Ki67, which is the proliferative marker, was very high, reaching up to 80%. So we could now come to a conclusion that it is a lymphoma, non-Hodgkin lymphoma, CD20 and PAX5 positivity. It is a B-cell lymphoma with a high Ki rate of 80%. So we are looking at a high-grade B-cell lymphoma. So to know the cell of the origin, we again continued our IHC with CD10, BCL6 and MUM1. CD10 and BCL6 were definitely negative in the tumor cells, and MUM1 was positive, and it was accounting for more than 30% of the cells as per the Hans algorithm. And we could now say that the cell of origin was non-GCB, which is nothing but non-germinal center origin B cell. And we also did BCL2 for double expressor status and CD30, which were also negative. Coming to the summary of the IHC, the tumor was pan-CK negative, CD45 positive, CD20 positive, PAX5 positive with high Ki of 80%. It was MUM1 positive, telling us that it is a non-GCB origin B-cell lymphoma. So coming to Hans algorithm, as we all know that we could diagnose this tumor as non-Hodgkin lymphoma, B-cell high grade, which we finally concluded it as diffuse large B-cell lymphoma NOS variety with non-GCB origin. So as we all know, what does the Hans algorithm say? Either CD10 positivity or BCL6 positivity with MUM1 negativity, we say that it is germinal center origin. So whenever there is MUM1 positivity, we classify that into non-GCB positivity. So in this case, it definitely had MUM1 positivity, so it belonged to non-GCB subtype. So I will not get into the details. I just wanted to conclude my presentation with approach to large cell lymphomas. So whenever you see a diffuse pattern of lymphoma, non-Hodgkin, composed of monotonous population of cells or single type of cells, whenever the size of the cells are small, you have to consider a differential of mantle, marginal, and lymphoplasmacytic lymphoma. And when you see the intermediate cells, you have to consider a differential of Burkitt's and lymphoblastic lymphoma. And when you see the large cells composition in a diffuse pattern, you have to consider a differential of DLBCL, which is nothing but diffuse large B cell lymphoma. And to finish off, you also have to look at the double expressor as well as double hit and triple hit status. What you mean by double expressor status? Where the immunohistochemistry wise, if they are expressing MYC and BCL2, you call them as double expressor type. They usually belong to non-GCB type. But when they molecular genetic wise, if they are expressing MYC and BCL2 with or without BCL6, you call them as double hit or triple hit lymphomas. The cutoff for BCL2 for IHC expression in double expressor is more than 50%. For MYC, it is more than 40%. So that is how you classify the DLBCL into double hit or double expressor status. I'll not get into the theory part of the DLBCL. So just to mention that we did experience so many DLBCLs being presented in the extranodal sites. We have reported the cases in tonsillar fossa, mediastinum, GI masses, stomach, jejunum, ascending colon, breast, skin, as well as bone. So it is very important to recognize something which is very easy to pick up in a lymph node. It is very difficult sometimes to pick it up in an extranodal site, especially bone and breast, where you don't expect them to be presenting that way. So definitely a comprehensive approach of morphology, IHC, along with or without molecular testing is very, very essential for you to pick it up. So we would like to thank KCIAPM for this wonderful opportunity to present our interesting cases. We would look forward to further more opportunities like that. So thank you one and all.
Thank you. With that, I thank the teams from Kempegowda Institute of Medical Science, Bengaluru, and also yes. With that, I thank the teams from Kempegowda Institute of Medical Sciences, Bengaluru, and also the Vaidya Institute of Medical Science and Research Center, Bengaluru, for conducting such a beautiful site seminar. I'm sure the PGs and all the delegates who joined us have learned a lot from the session. I would like to also inform that the certificates have already been shared with all the faculty and PGs who presented in today's seminar. And the slide seminar for the month of April will be conducted on 26th April by Yenapoya Medical College, Bangalore, and MR Medical College, Kalburgi. The slides have already been uploaded on the portal. Please do have a look at them and submit your responses before 26th of April. With that, I thank all of you for joining us, and we'll be closing the session. I thank the organizing family members from KIMS and VIMS Bengaluru, and also the PGs for joining us for the session.
Thank you.